Okay, so to begin with, am I audible? Well, audible?
Yes.
Okay. So namaskar and a very good evening to all the glitterati of AOGSBJ. A very warm welcome to all of you. Bokaro Society feels honored to host this webinar today on ensuring safe motherhood. And I, Dr. Divya Rashmi, along with my colleagues, Dr. Alka Tiwari and Dr. Varuna Jha, will take you through the webinar today. Myself especially, I also take this opportunity to pay my respects to my teachers and mentors, many of them who are here present today, and I see them on board today. My pranam and respect to all of you. My pranam and welcome to our patron and founder president, Dr. Rangila Sinha Madam, President, Dr. Anita Singh Madam, Secretary General, Dr. Pallavi Roy, ma'am, and all the senior faculties who are present here today. I also extend a very warm welcome to all my colleagues and my juniors who have logged in for this webinar today.
Hello.
Now we will begin with a small prayer to invoke Bhagwan Ganesh, the Vignaharta. The prayer will be sung in the soulful and melodious voice of Dr. Rupam Singh ma'am. I request Dr. Rupam ma'am, please, could you begin the prayer?
Namaskar. Astu ma sadagamaya tamso ma jyotir gamaya mrityorma amritam gamaya nizare ma pani ni pamare re ma pani pamare re ni sa Vakritund Mahakaya Surya Koti Samaprabha Nirvignam Kurumandeva Sarvakarishu Sarvada Namaskar. Thank you.
Thank you, Rupam ma'am. Thank you for this beautiful prayer, this beautiful rendition. May the blessings of Bhagwan Ganesh be with us today. So to begin, first of all, I would request our patron and founder president, Dr. Rangila Sinha Madam, to give her blessings and to say her words of wisdom. Rangila Sinha ma'am, please.
मैम अनम्यूट कर लीजिए अपने आप को मैम रंगीला मैम
Am I audible?
Yes, ma'am. Yes, ma'am.
Yeah. My blessing is always with you. I have started it and I see that how much progress it is doing day by day. And at present, this all the activities and समझो कि इसका बागडोर जो है वो डॉक्टर अनीता सिंह के हाथ में है. And Dr. Anita Singh is so expert and she is doing very meticulously everything and very silently. Not many much noise and voice, and without silently she is working. I'm seeing all her activity towards AOGSBJ and I am happy. she is very silently attending many societies. And this is very nice of her that she has attended recently Darbhanga Society and one more society. And this is Sitamarhi Society also. And one by one, we are covering all societies with CME. Practical CME is not possible. Everybody realize it. Then all society going from one society to another society, if it is very near, then it is okay. Otherwise, webinars, this is a new tool in our hand, which we can use for meeting many people, contacting many people, spreading our knowledge, disseminating our knowledge without much exertion. Especially in case of me, aged people like me, they can also enjoy this scientific and social activity from the comfort of their house. So I think that there is not much difficulty in organizing every month CME or webinar in every society, and that give you a stimulus for studying. I always say that a doctor is always a student till he dies.
Yes, ma'am.
And this is applicable with me, with all disability, so many disability, physical, mental. I'm trying to overcome it. And I'm trying to keep myself as much possible up to date as possible. And this is webinar which is actually helping me. So I am very much obliged to all of you. You are organizing webinars. I will hear what you are talking. Now, whatever I can't do myself, I want to see you people doing it. And it gives me great pleasure that when you are doing, and now at present, AOGSBJ is not a sapling, but it is a big tree. And you have made your own identity. Now, I think when outside the state, there is a recognition of AOGSBJ. People always want to say that AOGSBJ, एक society को पकड़िए पूरा AOGSBJ is yours. So now it is not Ranchi, not Jamshedpur, not Muzaffarpur, not Sitamarhi, but it is AOGSBJ. And my blessing is with you that you always try to do your best. And I am always with you as far as I can. So with this blessing, I want to start your CME scientific activity.
Oh, thank you, madam. Thank you, Rangila ma'am. May God always keep you in good health, in the best of health, and may you always keep blessing us. Thank you, madam. I would now request Dr. Anita Singh ma'am, our president, to give her presidential address. Anita ma'am, please.
Thank you, Divya. First of all, wish you all a very good learning evening. And I am thankful to Dr. Madam Rangila Sinha, who has praised me such a lot in front of you. Majority of what the praise for me is just because of her love for me. I'm doing whatever I can do for the society, that responsibility she has given to me. And I'm very happy to see all the societies having put together in this conference, and Nivedita has tried her best to include most of the societies in AOGSBJ, and so that everybody starts taking keen interest in this joint endeavor of ours. Because, you know, alone we do not have much strength. but when we are put together, we are actually great. And now the time has come, and most of the people are now, as Madam said, AOGSBJ is gaining popularity amongst our own members also. And we must be doing good programs like this one and the previous one that we have done. And it is my earnest request to each and every society, especially the president, secretaries, and the young brigade, the youth brigade, to come out with their ideas and come forward and propose some activities of their own interest so that we can have more and more such activities in the future. Organizing a web conference is not a big deal. It doesn't need much of expenses and discomfort on the part of the attendees also. It is very easy, and at least one of the Sundays we can devote to this AOGSBJ clinical meeting, and that should be of good standard, and we should be covering very good topics so that actually it is helpful for our members. So today's topic have been selected by me as well as by Dr. Nivedita together. And my talk is a simple talk on hyperemesis gravidarum, which is, I think, going to be the starter for the feast. There is nothing much in it, but the two topics that have been selected for panel discussion are actually the burning topics of obstetrics. Diabetes in pregnancy, or GDM in pregnancy, you can say, it will never go, especially in our part of the world. It is so common. And yesterday only I saw a patient who had 32 weeks pregnancy. She was simply getting twice a day insulin N, and her blood sugar, all the readings were above 170 and 180. And she had been advised to get her blood sugar done fasting and PP every 10-15 days. So that is not the ideal management of diabetes. That was nowhere near the ideal management. So I think we need this type of programs, and it is my earnest request to motivate all the obstetricians who are practicing to attend this program so that we can be par with the management that is being advocated for these patients, and we do not fail back, and we should provide the best for our patients who is attending the antenatal clinic. Otherwise, all these CMEs are of not much use. So more and more number of people should be informed about it and should be motivated to attend such program, so that the effort that have been put by the moderator and the panelists will be fruitful to all of them. So with these words, I am going to wish good luck to this CME, and I hope the attendees will go back with the revision of their knowledge, always as some new things they will be able to learn from this webinar. And once again, I wish great success to this webinar. Thank you very much, Nivedita. And thank you everyone, whoever have contributed in the organization of this program. And thanks to the attending people who are there to make it a success. Thank you.
Thank you, madam.
Thank you, Madam Anita ma'am. As your student, we have always admired you and looked up at you. Thank you so much for the presidential address. I would now request the Secretary General, Dr. Pallavi Roy ma'am, to give her secretary's address. Dr. Pallavi ma'am.
Unmute karo.
Ma'am, please unmute yourself.
You have to unmute.
Oh, sorry. Good evening. I welcome you all in this webinar organized by Bokaro Society, and it is fruit of hard work of Dr. Nivedita. I welcome Madam Rangila Sinha, Madam Anita Singh, our Vice President, Dr. Pratibha Rai Madam, Dr. Pratibha Singh, our Joint Secretary, Dr. Abha Rani. I welcome you all in this webinar. Previously, we organized one actual meeting in Muzaffarpur in the month of February. And after that, Sitamarhi Society organized on 26th of March about the endometriosis. It was attended by many members of AOGSBJ. And this Bokaro Society was to organize in April, but we are meeting today. It is very good. And June, Saharsa Society is supposed to organize one meeting. We have not discussed it with not discussed with Kalyani Di. We will talk to her. And in between, Anita Di attended Siddhamari and Darbhanga Society. And due to any confusion or what, no other office bearers could attend this. But in future, I think when this type of conference will be organized, our office bearers will also attend. So अनिता दी कुछ हम लोग बात कर लें आगे का.
हाँ.
तो ये
हाँ,
जून
मैडम.
में, हाँ
हाँ,
जून
मैडम.
में जो कौन है, जून में कल्याणी दी से बात करना होगा जून के लिए. और दूसरा एक हम लोग को मिड टर्म जो धनबाद सोसाइटी को करना था, तो उसका क्या डेट होगा प्रतिभा दी बताएंगी कब वो करेंगी.
उसके लिए पल्लवी हम लोग ऐसा कर सके ना, बाद में ऑफिस बेरर का एक मीटिंग
We can talk later on.
just now we should proceed with the scientific program proposed for today.
Yes. Yes.
Okay. Okay.
We'll organize another meeting with the office bearers sometime.
So
Maybe
this
Abha, we can arrange it for the next Sunday.
Abha,
Dr. Abha? Dr. Abha, unmute yourself.
हाँ जी मैडम, जरूर. Next Sunday we'll have a meeting ना.
Or we'll organize a meeting.
Yeah, we'll organize a meeting of the office bearers and there we can decide what to do, what are future plans.
जून पर करोगी
जूम पर दी, जूम ही पर करेंगे तो सब लोग मिल सकेंगे ना, सब जगह के लोग.
जूम पर ही ठीक रहेगा.
जी मैडम.
ठीक है. Today we should go exclusively for the scientific program.
ओके.
आभा भी बहुत एक्टिव है. हम आभा का नाम नहीं लिया, हम सबका अलग अलग नाम नहीं लिया.
नहीं, प्रणाम मैडम, आपका आशीर्वाद रहना चाहिए मैडम.
और उषा हमारी फ्रेंड है, उषा को भी नहीं एड्रेस किया. तुमको देख रहे हैं.
डॉक्टर निवेदिता. So
Yes,
let us
ma'am.
Dr. Nivedita, now you can
सबको by name एड्रेस करना चाहते थे, because of shortage of time I didn't do that.
Yes, Nivedita.
Divya, please continue.
Okay, so with that, thank you so much, Pallavi ma'am. So with that, we come to this end of the inauguration, and we will now begin with the first session. And I would like to ask Dr. Varuna Jha to begin, to take over. Dr. Varuna.
Good evening, everybody. Good evening, my respected teachers and
Chitrakala, if you could just stop screen sharing for some time, please, just for 2 minutes. Thank you.
Yeah, good evening, everybody. Good evening, madam. Good evening, my respected teachers. For the first session, which is on hyperemesis gravidarum by none other than our beloved Dr. Anita, madam from Anita Singh, madam from PMCH, who has been a teacher to all of us. For this session, I would like to invite, first of all, I would like to invite Dr. Usha Nath, madam, to chair this session. She has been, she doesn't need any introduction. Actually, her exemplary work has always been on cervical cancer and colposcopy, and she has trained a lot of people. She has started a training program for colposcopy, and she has written a lot of papers and research papers on cervical cancer prevention and colposcopy management. For chairing this session, I would also like to invite Dr. Pratibha Rai, madam, who is HOD PMCH Dhanbad, who is vice president of Ops and Gynae Society of Bihar and Jharkhand, and she is immediate past president of Ops Gynae Society of Dhanbad Ops Gynae Society. And she has presented papers at various national and international and chaired sessions at various national and international seminars. So I would like both madams to chair this session. May I request now Pratibha Rai madam to introduce Anita Singh madam and to tell us in brief about this topic about hyperemesis gravidarum. Thank you.
Yes. Good evening and johar to my seniors and every member and dear colleagues. Today, our first topic is hyperemesis gravidarum, which is a severe form of morning sickness, and it is related with early pregnancy, but it may be a manifestation of some medical and surgical complication. And also, if not, it should never be taken lightly because it has so many deleterious effects on the health of the mother as well as on the health of the mother. It can lead to dehydration, electrolyte imbalance, anxiety, irritability, features of ketoacidosis, and it also damages our organs if not treated properly or not taken seriously. And sometimes it may lead to esophageal perforation, hepatic disorder, pulmonary edema, seizure, blindness, and even coma and death. As whole family, including patient, are in serious position. So emotional support is also very needed. Fetal outcome is also affected if not treated properly. So as hyperemesis is a diagnosis of exclusion, so early hydration and proper investigation to reach the final diagnosis is must. So this topic, which we should never take it lightly, today our senior Dr. Anita Singh ma'am, dearest Anita, the ex-professor Patna Medical College, Vice President Foxy, 2020 to 2021, past VP, then Chief Consultant at hospital and Jan Chikitsa Hospital, past President Box, Organizing Secretary of AICOG 2014 at Patna, Chairperson Endocrinology Committee, Foxy, 2014 to 16, Governing Council Member AICOG, and President AICOG Bihar Chapter. So, welcome you, Madam. You are so near and dear to us. And nowadays, we all know that you are Vice President of AOGSBJ, and you are going to deliver a talk on this very dreadful complication of early pregnancy. So, now I request you, Madam, to throw your knowledge in this very, very important topic, which so many doctors not take it seriously. Just think, oh, it is the normal thing, it is morning sickness. But I think your topic will open the eyes of each and every doctor, and doctor as well as patient must be benefited from it.
Thank you, Pratibha, for such a nice introduction. And Pratibha has briefly outlined what is hyperemesis gravidarum and how we should be prepared to deal with it and apprehend the complications that may occur. So I'm going to talk about this hyperemesis gravidarum in next 15-20 minutes. I'll be touching the salient points, brought out from the latest literature, what it suggests, and latest recommendation, what are those? I have tried to include all those things in my talk. Next slide, please. First of all, it's a spectrum of the disease. And the spectrum in the earliest form is simple nausea. Sometimes it is associated with vomiting. But at the end of the spectrum of this disease, it becomes hyperemesis gravidarum when it is uncontrollable, and it starts causing harm to the general health of the patient herself. It occurs in the first trimester of pregnancy. Some sort of nausea and vomiting is found in about 70 to 80% of the pregnant women. It usually starts 4 to 7 weeks after the LMP, and it peaks around 9th week to 10th week of pregnancy. And generally, it spontaneously abates by 14th week of pregnancy. But in about 50% of the patient, it can linger up to 22 weeks of pregnancy. It should be diagnosed when the onset of nausea vomiting starts in the first trimester, not before that, or not in the second trimester. When it starts in the second trimester, we should be thinking about the other causes of nausea and vomiting, not emesis of pregnancy or nausea and vomiting of pregnancy. Now coming to the hyperemesis gravidarum, how we can classify that this patient is not suffering from simple nausea and vomiting. Now she has reached the stage of hyperemesis. It is the worst form of nausea and vomiting of pregnancy, and it is defined when there is persistent vomiting with the triad of symptoms like dehydration, patient lose her weight more than 3 kg or 5% of her previous weight, and she develops electrolyte imbalance, either hypokalemia, hyponatremia, and hypochloremia. So if there is electrolyte imbalance because of the vomiting, then she is not a simple case of nausea, vomiting, or pregnancy. Now she has become a case of hyperemesis gravidarum. It can bring about complications in about few number of cases, but this hyperemesis gravidarum is found luckily in only 0.3 to 1.5% of the pregnancies. The rest of them end with simple nausea and vomiting. Recurrence can occur in the future pregnancy to the extent of 15 to 80%. Next slide, please. There are some risk factors which have been found to be associated with hyperemesis gravidarum. And the risk factors are multiple gestation, haitiform mole. When the patient has not used multivitamins, either perinatal in the pre-pregnancy period or in early pregnancy, it is more common. If the patient had heartburn or acid reflux from before, it is more common in primigravidas. And whenever there is motion sickness in the patient, there are more chances of having nausea and vomiting of pregnancy, up to the extent of hyperemesis. Sometimes patients who had migraine, they are more prone to develop it. And it has been found more commonly with the female fetuses. And there is some sort of family history also of hyperemesis gravidarum. Next slide, please. It was thought that nausea and vomiting of pregnancy is some sort of defense mechanism against the toxic substances which the patient can consume and can harm to the fetus initially. But actually, this hypothesis is not true. Mild nausea and vomiting of pregnancy has been found to be associated with better outcome of pregnancy, which indicates high HCG level, and there are less chances of patient undergoing in the future having miscarriage. So it's a good thing if you think about the continuation of pregnancy, especially in cases who have conceived after IVF, after a lot of previous abortions. When she continues with the nausea and vomiting, we think that the HCG level and progesterone level is, estrogen progesterone level is high. That is why this patient is having so much nausea and vomiting. So in that way, it is a reassurance for the continuation of pregnancy. Next slide, please. If you come to the etiological factors, there are several. It can be hormonal changes because of the prostaglandin E2 and leptin levels, because of the infection with H. pylori in the stomach, maybe because of abnormal gastric motility. Genetic factors are also being implicated in the etiology of hyperemesis gravidarum. In some patients, it may be because of the psychological factors who somehow or other they want to reject the pregnancy. Next slide, please. If you look at the hormonal changes, it is the high HCG which have been seen to be associated with hyperemesis. And that is why it is so common with trophoblastic disease, as well as multiple pregnancy when there is high level of HCG. It is also because of the high level of estrogen and progesterone. We have seen that whenever you put the patient on COCs, which contain estrogen and progesterone, initially the patients have a lot of nausea and vomiting. It may be because of that the body does not accept such a acute rise of estrogen and progesterone in the body in pregnancy. And these hormones also relax the smooth muscle and thus slow gastrointestinal transit time, and they can alter gastric emptying that encourages vomiting. There is also relaxation of the lower esophageal sphincter, which allows more and more of vomiting. And there are other hormones also which are present and secreted from the placenta that are responsible for more and more of vomiting. Next slide, please. But there is a lot of controversy in all these hypotheses or association, you can say, because the HCG level is very high in the choriocarcinoma, but the patient does not present with vomiting or nausea or hyperemesis. Similarly, estrogen levels are very high in the later part of the pregnancy, but usually this nausea and vomiting abates in the late second trimester. So there are controversies regarding the exact role of these hormones in the causation of hyperemesis gravidarum. Next slide, please. Similarly, gastric dysfunction or dysrhythmia leading to delayed gastric emptying has been thought to be an etiological factor. And there was a good study and a meta-analysis that found that there was a significant association between H. pylori infection and hyperemesis gravidarum. Next slide, please. Next one. Psychological factors we have already talked about. Next slide, please. Now, a word about PGE2 and leptin. Placental PGE2 has effect on gastric smooth muscles, and serum leptin levels have been found to be significantly higher in those patients who have hyperemesis gravidarum. So these two biochemical products are found to be associated strongly with hyperemesis gravidarum. There has been a lot of research on the genetic factors, and it has been identified that presence of GDF15 and IGF-BP7, both these genes are associated with hyperemesis gravidarum, and that is why this genetic problem has been found in some families where majority of the patients have hyperemesis gravidarum in their pregnancy. Next one. Now coming to the pathological and biochemical changes. Pathological changes are more or less same as seen in cases with severe malnutrition, because after all, this hyperemesis leads to malnutrition. In CNS, there have been found a small hemorrhagic spots in the hypothalamus, similar to that of Wernicke's encephalopathy due to vitamin B1 deficiency. In liver, it has been found to have fatty infiltration without necrosis. Occasionally, kidneys also show degeneration, fatty degeneration. In the blood, there is mild leukocytosis, hemoconcentration because of the dehydration. Next, please. Next slide, please. Yes. Metabolic effect may be because of the less intake of food, and there is depletion of glycogen stored, and fat is metabolized more and more, and that goes into ketone formation of ketone bodies, and patient starts having acidotic breathing, and there is excessive breakdown of proteins also to maintain the glucose level, and that leads to accumulation of nitrogen in the body. So the whole metabolism is affected because of the malnutrition and less ingestion of food. Next. Because of the hemoconcentration, there is decrease in urinary chlorides, which leads to alkalosis. Extracellular fluid is first diminished, and plasma sodium and potassium fall. Potassium deficiency due to rapid loss in vomitus. And there is also increased renal excretion. So there is severe potassium loss in few patients. And this hypokalemia itself leads to more and more of vomiting, which together leads to liver damage. And it is a vicious circle which is established unless and until it is properly recognized in time and the circle is broken. Next slide, please. So how do the patient clinically presents to us? The patient presents with lot of nausea and vomiting, with weight loss, tachycardia, sometimes hypotension also. There will be physical signs of dehydration. Next slide, please. Next one. The previous one. The previous one, please. So the clinical presentation will be dry coated tongue, sunken eyes, oliguria, loss of skin elasticity. Sometimes there is hypersalivation in these patients, and rise in temperature can occur because of the dehydration, ketoacidosis, etc. And there will be a smell of ketone in the breath of these patients. Next slide, please. So how can we assess the severity of nausea and vomiting of pregnancy? Because in a glance, we should not carelessly talk to these patients and simply pass away that she is having nausea and vomiting of pregnancy. We should be very careful about it whenever there is chance of hyperemesis. And the objective and validated index of nausea and vomiting is pregnancy unique quantification of emesis, that is PUQE, a score. And that classifies the severity of nausea and vomiting of pregnancy. It was previously of 12 hours reading. Now it has been modified to previous 24 hours study of the problem. And then the patient is classified in which category does she fall. Next slide. So there are 4 points. There are 3 points which are considered. First is how long she feels nauseated. Second one is how many times she vomits or throws out. And the third point is how many times she had retching or hips without bringing anything up. So these 3 points are taken into account, and number of these occurrences are noted, and the total joint number of these 3 points denote in what category that patient falls. If she has got a total score of less than 6, then she is of mild nausea and vomiting and pregnancy category. If she has got between 7 to 12 score, then she is a moderate category nausea and vomiting of pregnancy patient. And if it is more than 13, then it is of severe category, and then she will fall into the category of hyperemesis gravidarum. Next slide, please. But whenever there is a case of nausea and vomiting of pregnancy, we should take also into consideration while asking the history, examining the patient, that she doesn't have anything other than nausea, vomiting or hyperemesis gravidarum. Because similar symptoms can appear in appendicitis, gastroenteritis, intestinal obstruction, twisted ovarian cyst, but of course, all these will be associated with abdominal pain also. Sometimes patients with cerebral tumor can have a lot of vomiting. Even pyelitis, uremia can present with vomiting. But all these also have other symptoms like headache. In cerebral tumor, she will have headache. In pyelitis, she will have burning micturition, she will have fever from initial stage. And this sort of vomiting can be present in preeclampsia, HELP, acute fatty liver of pregnancy. But all these are symptoms of late pregnancy, whereas hyperemesis occurs in early pregnancy. Pancreatitis, one can have a lot of vomiting, migraine, sometimes hyperparathyroidism. Hyperparathyroidism in pregnancy can present with hyperemesis gravidarum. Next slide, please. So we should be alert on all these points, and if there is any doubt, we should do investigations on that line and exclude all those problems. Now, how we'll initially assess the patient? First of all, after doing a general clinical examination with the noting of her vital parameters, we'll look at the urine, we'll test for ketonuria, midstream urine should be sent for culture and sensitivity. Her urea and electrolytes should be estimated to know her general metabolic status. Is she having any hypokalemia, hypochloremia, hyponatremia, or are there any features of renal involvement? Full blood count should be done to know the extent of hemoconcentration by looking at the hematocrit, and also to look for any other associated infection that has led to so much of vomiting. Next slide, please. Next slide. Next one, please. Blood glucose monitoring should be done. If the patient is diabetic, then we should be very alert for ketoacidosis. These patients are very prone to going into ketoacidosis very soon. Then we should do an ultrasound to see a viable pregnancy and also to exclude multiple pregnancy and molar pregnancy. Next slide, please. In refractory cases or history of previous admissions in these patients who are not responding well, we should go for thyroid testing, especially for hyperthyroidism. Liver function test should be done. Calcium and phosphate should be estimated. Amylase should be done to exclude pancreatitis, and to know the extent of metabolic disturbance, her blood gas analysis should also be done, acid-base analysis. Next slide, please. Now coming to the complications, we should know the complication which the patient is likely to suffer. We have known the extent of the disease, the involvement of the different systems that she does have or she doesn't have. Then we start thinking about the complications that particular patient can undergo. The worst complication of this hyperemesis is wernicke's encephalopathy. What happens in that? It is because of the thiamine, acute thiamine deficiency. It classically presents with blurred vision, unsteadiness, confusion, memory problems, and drowsiness. So all CNS symptoms are present in those patients. And on examination, she can have nystagmus, ophthalmoplasia, hyperplexia, gait instability, finger nose ataxia. When you ask to touch her nose, she will be showing ataxia. In hyperemesis, the presentation tends to be episodic and slow onset. And this encephalopathy is potentially fatal if not diagnosed early and managed well. So we should be always concerned about this complication whenever you are dealing with a case of hyperemesis gravidarum. The treatment of this problem is very simple, or prevention is very simple. Whenever the patient presents with hyperemesis, you should not forget about giving her thiamine in very high dose. Initially, it should be given 100 milligram per day, IV. It is mixed with normal saline and then given slowly for 3 days. And then it can be followed by oral supplementation if the patient can tolerate. Next slide, please. There are several preparations available in the market of B complex and even single drug, that is thiamine there, 100 milligram per ml is available, and we can easily give that to any patient. It doesn't cause any harm. So whenever there is doubt of hyperemesis, we should not forget about giving thiamine to these patients. Other complications that can occur because of excessive vomiting is splenic avulsions sometimes occur, although rare. Esophageal rupture can occur, or one of the vessels in the lower part of the esophagus can rupture and the patient can have melena and hematemesis. Pneumothorax can rarely occur. Sometimes there is peripheral neuropathy because of the deficiency of vitamins. And these patients are more prone to develop preeclampsia. And in these patients, there are more chances of having premature delivery and delivery of growth retarded fetuses. Next slide, please. So how to manage these patients? Next. The principles of management of hyperemesis is initial stabilization of the patient and correct dehydration, for which, along with the dehydration, we should also take care of the electrolytes so that correct fluid should be initiated. Antiemetics should be given parenterally to stop further vomiting, and dietary measures and behavioral changes will come as the patient improves. Next slide, please. Next one, please. Now coming to the management of hyperemesis or vomiting itself. What are the pharmacological therapies that we usually give? First line therapy is non-pharmacological agent. Whenever a patient presents with nausea, vomiting, I'm not talking of hyperemesis. Whenever the patient presents early pregnancy with nausea, vomiting, what do? We always give folic acid supplementation. We advise her to take ginger capsules, or we ask her to take ginger in the morning right on the bed. So all these things are done. If the vomiting starts occurring or persists, then we switch on to pharmacological agents. And the first line of therapy recommended by all over the world, by all the renowned societies, are combination of pyridoxine and doxylamine. A lot of preparations are available on the market. They can be given. Each tablet contains 10 milligram of both of these elements, and 1 to 4 tablets per day can be given easily to this patient. It is very safe and it is category A drug. So it can be given up to 4 tablets per day, 1 in the morning, 1 in the afternoon, and 2 tablets at the bedtime if she doesn't respond to 2 tablets at bedtime initial dose. If the patient fails to respond to this first line treatment, then of course we'll have to switch on to second line of therapy, and that can be preparations of dimenhydramine. All the antihistaminics can be given: dimenhydramine, diphenhydramine, prochlorperazine, promethazine. Either of these drugs can be, whichever is available and whichever suits to the patient, can be given in the recommended doses every 4 to 6 hours. Next slide, please. If in spite of that line of therapy, the patient still persists with vomiting, then one can go for metoclopramide, 5 to 10 milligram every 6 to 8 hours, or ondansetron, 4 milligram every 8 hours, or it can be given IV 12 hourly in severe cases. One can also give promethazine, ebomine or estimetil, 12 to 25 milligram every 4 to 6 hours, orally, rectally, or intramuscularly can be given. So either of these drugs, depending on the severity, can be given, and most of the drugs have been proven to be of no harm if given in early pregnancy. There has been a lot of debate and research on ondansetron, but now it is being recommended that it can safely be given in cases of hyperemesis gravidarum. Next slide, please. When should the patient be admitted? What are the criteria for admission? If there is continued nausea and vomiting, inability to keep down oral antiemetics, continued nausea and vomiting associated with ketonuria or weight loss, then she should be admitted. Confirmed or suspected comorbidity such as urinary tract infection, intolerance to oral antibiotics, and whenever she has got a PUQE score more than 13, the patient should be immediately admitted to prevent future serious complications. Next slide, please. Next one. First of all, our duty is to correct the dehydration. So after admission, the dehydration should be assessed depending upon her weight and measurement. Police catheter should be put in to see the urinary output and the state of hydration. IV fluids are started. Usually we should start with normal saline, and we should avoid any dextrose, because if we give dextrose in a dehydrated patient, that can lead to Wernicke's encephalopathy. So this point is very, very important, that in these patients, dextrose should never be given initially, and you should always start with normal saline. And normal saline should be given very fast. You can give 1 liter of normal saline in just 2 hours within the time of, after the time of admission. Total volume replacement, that is 3 liter per day, can be done in next 24 hours. IV antiemetics should be started, and ondansetron or metoclopramide is the drug of choice for IV antiemesis. Antiembolic, because these patients have dehydration and hemoconcentration, and pregnancy is a thrombotic state, they are likely to have thrombosis and thromboembolism. So for that, thromboembolism prophylaxis should be given by stockings or low molecular weight heparin. Next slide, please. If there is persistent vomiting, then chlorpromazine, that is Larzeptil, can be given in the dose of 25 to 50 milligram intravenously or intramuscularly. In worst cases, when she doesn't respond to all these treatments, her vomiting still continues, then one can go for methylprednisolone. Should start with high doses, 16 milligram every 8 hours for 3 days initially, and then one should try to taper down the dose and maintenance should be given with the minimal doses which can take care of the bleeding, and that minimal dose should be continued for 6 weeks. Next slide, please. Now coming to the electrolyte imbalance, one must do the electrolyte estimation of the patient, and depending on the electrolyte imbalance, any hypokalemia, if it is present, it is corrected with 20 to 40 millimoles per liter of potassium should be given. Correction of acidosis and hyponatremia usually occurs with the infusion of normal saline. You do not need to give high concentration of normal saline that can cause further complications. Next slide, please. Magnesium, if she is deficient in magnesium, then one can easily give 2 grams of magnesium, initial magnesium sulfate as a 10% solution, which is available for the treatment of eclampsia. So 2 grams of that can be given slowly IV over 20 minutes, and that should be followed by 1 gram in 100 ml per hour for next 24 hours. By that, her magnesium deficiency is usually corrected. Urine output should be monitored very strictly, and depending upon the urine output, further hydration should continue. And urine should also be looked for ketone bodies, specific gravity, blood urea, and electrolytes. Next slide, please. Along with it, we should give adjuvant therapy with B1, B6, and B12 because these patients are deficient in all these vitamins, and that is why there is peripheral neuropathy. Vitamin C should be supplemented. Pyridoxine should be given IV, 25 milligram in 1 liter of fluid daily. And then the patient should be continued with combination of doxylamine and pyridoxine. Each tablet, 2 to 4 tablets per day. Thiamine, I have already talked about initially, should be given 100 milligram IV every day for 3 days at least. Folic acid should be given along with this if she is not already on a folic acid tablet. Next slide, please. We have already talked about recommended antiemetics. Once again, I want to emphasize we should start with combination of pyridoxine doxylamine. It has been approved by all the societies and it is a first-line therapy. If you need, then only you should go to the second-line therapy. That can be metoclopramide, promethazine, prochlorperazine. Prochlorperazine is category C, but metoclopramide is category B drug, so one can easily give this. Next slide, please. Antihistaminics are category B drugs, and those can be given diphenhydramine or dimenhydramine. Either of these two can be given. Even ondansetron is category B drug, and it can be given in the resistant cases. We do not respond to the previous drugs. Next slide, please. Corticosteroids are category B drug. Its side effects include hyperglycemia, increased risk of orofacial defects in the fetus in the form of cleft lip and cleft palate if given in the first trimester. Usually these drugs are required in the first trimester. So whenever you are prescribing methylprednisolone, you should warn the patient and her attendants there are chances of occurrence of cleft lip and palate, but just because it is going to be life-saving for the patient, there is no option but to give this drug to this patient at that moment. H2 receptor blockers are also given, ranitidine if there is gastritis associated with vomiting, and proton pump inhibitors are also category B drugs and if required can be given. Next slide, please. What is the mechanism of action of the basic drug that we give? That is doxylamine and pyridoxine. Doxylamine blocks the H1 receptors present in the nucleus tractus solitarius, that is CTZ, that is responsible for vomiting, and also acts on vestibular apparatus. Pyridoxine serves as a cofactor for enzyme glutamate decarboxylase and increases the synthesis of GABA, which serves as inhibitory neurotransmitter at CTZ. So that is the reason behind these two drug combination that is initially recommended for nausea and vomiting of pregnancy. Next slide, please. Role of steroids, that is the last drug that I have enumerated. In refractory cases, it has to be given. The decision should be made after talking to the patient. There is risk of osteoporosis, infection, and rarely aseptic necrosis of the hip. Fetal adrenal suppression can occur in few cases if there is prolonged use of this drug. So careful consideration should be taken before starting corticosteroids, before 10 weeks of gestation, and there are chances of 1 in 1,000 cases of developing cleft lip and cleft palate that you will have to counsel the patient that the chances are, although low, that is only 1 in 1,000. Next slide, please. Now coming to the dietary and behavioral changes, diet should be changed. She should be asked to take small meals every 2 to 3 hours. We should be rich in carbohydrate and low in fats because fat is more causes more vomiting. Eating plain biscuits, toast, some sort of ginger preparation in the morning is good. She should avoid very cold, tart, and sweet beverages. She should also avoid personal triggers like stuffy rooms, strong odors, heat, humidity, etc. Next slide, please. Parental nutrition is controversial and it is a last resort because parental nutrition has got its own side effects. It leads to infection and vascular perforation, etc. And it can be associated with severe complications sometimes. Nasogastric feeding is recommended by few, but it is not well tolerated usually. In few cases, people have gone for jejunostomy and feeding. That is tolerated, but it is not into practice in most of the I do not think anybody who has been put on this treatment, but this is a theoretical thing which I have come across in the literature. Next slide, please. Next one. Coming to the termination of pregnancy. The Hyperemesis Education and Research Foundation in the USA report that 10% of the pregnancies complicated by hyperemesis gravidarum end in termination. But one should always defer termination as far as possible because there are chances of recurrence in the future pregnancy also. So if the patient wants to have the pregnancy, that should be the last and the remotest thing that one should offer or the patient should ask for it. And before deciding for termination, one should take multidisciplinary opinion, including a psychiatrist regarding its institution. And women should be offered counseling before and after a decision of pregnancy termination, whenever it is finalized by the patient and the doctor. Next slide, please. Prognosis is usually good. This simple nausea vomiting begins before 9 weeks and abates by 20 weeks gestation. 3% of the patient continue with this vomiting and nausea throughout their pregnancy. Approximately 10% of the patients with hyperemesis will be affected throughout the pregnancy with vomiting, and throughout she may need IV infusion for hydration off and on. But luckily, hyperemesis does not appear to become more likely with each pregnancy. And after one pregnancy with hyperemesis, the following pregnancies may be different and she may not have any nausea vomiting or may not have any hyperemesis. So the patient should be counseled for that she should not get panicky about carrying next pregnancy. If she had suffered from hyperemesis, next pregnancy may be normal. She may not have any nausea and vomiting. That is possible. Next slide, please. So at the time of discharge, the patient should only be discharged once the vomiting ceases or occurs for less than 3 episodes per day. And she is advised to continue with her antiemetics and return to hospital if there is exacerbation of the symptoms. One should always avoid giving her oral iron therapy. That may again exacerbate her vomiting. If she has got continued symptoms in the 2nd and 3rd trimester, then she should be offered serial scans to monitor the fetus because the fetus is likely to suffer from growth restriction. Studies have shown that women with hyperemesis have low pregnancy weight gain, Less than 7 kg usually they gain throughout pregnancy, at an increased risk of preterm delivery and low birth weight babies. Next slide, please. Next one. Regarding future pregnancies, there is risk of recurrence up to the extent starting from 15 to 80%. Early use of lifestyle, dietary modification, and antiemetics found to be useful in the index pregnancy is advisable to reduce the risk in the next pregnancy. And early use of doxylamine and pyridoxine as an antiemetic has been shown to improve the results in the future pregnancy. And the patient should be put on folic acid when she plans to get pregnancy. It has been seen that putting on folic acid and pyridoxine from before pregnancy usually eliminates the risk of nausea and vomiting of pregnancy, or there will be less chances of hyperemesis gravidarum in the coming pregnancy. Next slide, please. The future perspective on this topic are more research is needed before the conclusive establishment of genetic factors, because it has come up as a new factor responsible for hyperemesis. Search for an effective, safe, and well-tolerated drug is still going on. Recent studies have shown hyperemesis to be associated with, to some extent, with autism in the fetus, but that has not been yet proved. Next slide, please. So the take-home points are: hyperemesis is a disease with multifactorial etiology. Doxylamine and pyridoxine combination is the first choice of antiemetic. Metoclopramide and ondansetron can be used as second-line antiemetic. Prompt management of the condition must be done, as it can lead to potentially life-threatening complications. Urea and serum electrolyte levels should be checked daily in women with hyperemesis gravidarum who are on intravenous fluids. Next. Dextrose-containing fluids should not be given for correction of dehydration, as it can precipitate wernicke's encephalopathy. Sodium correction must be slow. If you give concentrated sodium solution, then that can lead to pontine demyelinosis, again a serious complication. Thiamine supplementation should be given to all women admitted with prolonged vomiting. Women with hyperemesis who are admitted to hospital should receive thromboprophylaxis with low molecular weight heparin, unless there are contraindications to the use of this drug. Next slide. Women with hyperemesis who have symptoms extending into the late second trimester or beyond that should have regular scanning for growth restriction and timed delivery. In patients with hyperemesis in previous pregnancy, prophylactic supplementation with antiemetics should begin early to avoid hyperemesis. Daily intake of multivitamin with folic acid at least 1 month prior to conception reduces the risk of frequency and severity of nausea and vomiting in pregnancy. Next slide. Thank you all for the patient hearing. Thank you very much.
Aruna. Dr. Ushanath, ma'am, I would request you to unmute yourself. Ushanath, ma'am, you're muted. Yes.
Yeah. Well, thank you. First of all, I would like to thank the organizer and also very much lobbying Dr. Ranila Sinha to be present here. Anita, Abha, Nivedita, and Pratibha, and everybody else. I'm so glad to see you all. As far as the hyperemesis gravidarum topic is concerned, I was also thinking about it, that this is very unusual that this topic has not been very much sought after, or I haven't seen happen in so many webinars, but I have not seen people selecting this. So I was very happy. I'm very happy that this unusual topic, which could, if not taken care properly, can become fatal or even influence her health in future. So that is one thing which was all the time I kept thinking while listening to Anita. Anita, thank you very much. You have done a good job, and you have really touched every little thing about the hyperemesis gravidarum. And I don't know what else to add to that, except two things I would like to say. One is hyperthyroidism, in which the T4 is increased. Sometimes also affects because of the, it gets affected because of the hyperemesis gravidarum. Secondly, I have a question. When I was working in the UK, and in my early days as a senior house surgeon, I was there in Bellshill. I found few patients in Western world, probably it is more common, where the women would complain and say, I cannot tolerate the sight of this man, or this pregnancy is not my choice, is very unwanted, and she will be so ill. So I think there is some emotional factor also involved in the hyperemesis gravidarum time to time, and we should be able to differentiate that, and probably anxiolytic medication also may help there. So I'm really glad, Dr. Anita. It's very nice talk you gave, and every little bit of points you discussed. And now we are enlightened about that more. So thank you very much.
Thank you, ma'am, for the appreciation.
Thank you.
Psychological factor is always there. You know what I do when patients are repeatedly coming. I'm having this, I'm having that, I'm not getting relief of that. Every medicine I have tried, even injection. Then I say that you please get admitted in my hospital. And many times you will see that the very instruction that you have to be admitted in hospital, she never comes back. Either she might have gone to some other doctor, or the nausea and vomiting might have disappeared. So psychological factor is always there. And one thing I want to ask, what is it very common severe hyperemesis gravidarum in your practice? I have forgotten what I was practicing because I am not in active practice these days.
Rita ma'am, you need to unmute yourself.
Yes, madam. So far as my practice is concerned, every month at least I have to admit 2-3 patients with hyperemesis. If exactly it is not hyperemesis, but at least she's not able to tolerate anything as what she says and her attendance says. So I have to admit those patients and put on them with the treatment of hyperemesis as I have just now described. And I had to give 2 patients in the past, in all my clinical experience, I had to put those patients on even methylprednisolone. And both of them responded to methylprednisolone, luckily. And their nausea and vomiting was gone after that. Before that, I tried all the medicines and both of them did not respond. So I remember vividly that in 2 patients, I had to go for methylprednisolone. So I was very scared. Actually, I went through the literature and searched quite a lot, the side effects, this and that, and the dosage and all that. And then I put those patients on that, but that worked well.
So next time there should be interactive. This is disadvantage of this webinar, because you can't be in active. You can't see speaker in activity, and also you will be not in active. So that is disadvantage. So if it is interactive, this can be also hyperemesis gravidarum also. It can be case-based. This will be interactive.
I think you can invite the audience for any query if they have got.
Other questions, please ask other questions.
Ma'am, as a participant,
Chat
only
box
the
में question है.
ma'am, only panelists can put forward questions. जो
They can
attendees
put
हैं
their questions in the chat box.
and the attendees, whoever they are joined from the attendee list, they can put their questions on the Q&A. On your mobile or your laptop, you will see a column called Q&A. If you put your questions on that, then we'll get the questions. Thanks a lot for the attendees. And now, any questions
you.
from the panelists? Otherwise, Varuna, please.
Thank you very much, Anita ma'am, for such a detailed and for your personal input also about methylprednisolone. That was priceless. And thank you so much for enlightening us. And I thank.
Can you introduce yourself, please?
I'm Dr. Varuna from Bokaro. I'm Dr. Varuna.
Nice.
I'm OGSBJ. I've done my MD from RMCH. And for a brief time, I was also in Patna, where Anita ma'am, she wouldn't be remembering me, but I remember her very well. That we used to be very fond of her. Anyways, thank you so much, ma'am, for a very educative talk. And I also thank the chairpersons, Dr. Pratibha Rai madam and Dr. Usha Nath madam. And thank you so much for your valuable input, Dr. Rangila ma'am. You really lighten up the session. So I next call upon Dr. Anita, Dr. Alkadi to take this session forward.
Thank you.
Actually, we'll have the panel on stillbirth first before the next panel, the panel on GTM. So the next panel is a panel on stillbirth, and for which ma'am, yes, madam, madam needs no introduction. She is the president of Bhagalpur OBS and Gynae Society, and she is the East Zone coordinator of PSC Committee FOGSI. She is also the scientific chairperson of IMA Bhagalpur, and she was the organizing chairperson at 9th AOGSBJ. And the next expert is Dr. Supriya Jaiswal. She is the vice president of Patna OBS and Gynae Society, chairperson Adolescent Health Committee, and she's also the joint secretary of SUBSI Bihar and Jharkhand chapter. She's the chief consultant at SM Hospital, Patna. For the panel, we have moderators. I would like to invite Dr. Leena Nair and Dr. Kavita Bandwal. Dr. Leena Nair is the consultant obstetrician and gynecologist at Lar Clinic, Bhagalpur, and she was the past secretary of Bhagalpur OBS and Gynae Society. She's also the treasurer of Bhagalpur OBS and Gynae Society. Dr. Kavita Bandwal. Yes, madam is a senior consultant and laparoscopic surgeon at Samarpan Hospital, Munger. She's also an honorary teacher at Lord Buddha Medical College and Hospital, and she's a recipient of many awards, and one of them is the Kamlabai Hospital Award. And for the panel, I would like to invite the esteemed panelists. First of all, I would like to invite Dr. Amita Sinha. She is the secretary, POGS Patna, communicator for ISOPAV, and also the East Zone coordinator for Practical Obstetrics Committee of FOGSI. She also has many awards to her name. The second panelist is Dr. Asha Dolani. She is the clinical secretary of KOGS. The next panelist we have is Dr. Imrana. Dr. Imrana is the director and fertility specialist and endoscopic surgeon at Jan IVF Bhagalpur. She was the past secretary of Bhagalpur OBS and Gynae Society, and she has more than 500 IVF pregnancies to her credit. Dr. Meenakshi Kumari, she is the consultant at Khushi Clinic, Ranchi. She has been the past joint secretary of Ranchi OBS and Gynae Society, and she's also a member of the FOGSI MTP committee. She has many publications that we see on her name. Dr. Sangeeta Kumari is the consultant obstetrician and gynecologist at Sivan. And you can see as her CV is studded with awards. She has received many awards to her name. Dr. Shreya Karan, is the consultant obstetrician and gynecologist at Park Clinic, Dhanbad. We have Dr. Smita Singh. She's the Vice President of Muzaffarpur Obs and Gynae Society, and she's also the consultant at Amrit Mother and Child Hospital, Muzaffarpur. And we also have Dr. Tulika Joshi. Dr. Tulika is the Director and Consultant Fetal Medicine at Tulips Fetal Care, Ranchi, also consultant at Freya Hospital, Ranchi. She's the coordinator of Society of Fetal Medicine, Jharkhand Study Group, and she has numerous awards and publications to her name. Welcome all panelists, welcome moderators and experts. So I hand over to the moderators for the panel. Thank you.
Hello, good evening. Can you hear me?
Yes, yes, ma'am, we can hear you. Yes, ma'am, go ahead. We can hear you.
I'm sharing my screen actually. Can you see my screen right now?
Yes, ma'am, your screen is visible.
Or make it a full screen.
Oh, yeah, that's what I'm trying to do.
Click on the cup icon.
Somebody else is sharing, that's why I'm not able to share. Please stop sharing.
Somebody else is.
Dr. Leena, we can see your slides. It's already showing something on stillbirth.
I think I have started sharing. So is it
Okay,
not visible?
Dr. Kavita has started sharing.
No, don't share, Kavita. I will be
You are
sharing.
sharing. You are sharing, Leena di?
Yeah,
Okay.
I'm sharing,
Okay.
yeah.
Okay. Okay.
Stop
Thank
sharing.
you. Okay. Okay, let me stop. I think I will stop sharing.
Now full screen. Can you see the screen now?
Yes, ma'am.
Yes,
Full screen. Full screen.
Thank you very much. First of all, at the outset, I would like to thank the organizer, especially Dr. Nivedita, for giving us the opportunity, me and Dr. Kavita, the opportunity to moderate this very, very important panel discussion on stillbirth. We all know that stillbirth is very, very confounding problem. And for this panel discussion, we have experts, Dr. Rekha Jha, madam, our own president, then Dr. Supriya Jaiswal, the chairperson, Adolescent Health Committee, FOXY. For panelists, we have Dr. Asha Dolani, Dr. Imrana, I think they've all been introduced. Are all the panelists present? Is somebody absent? Are all the panelists available?
I think Amita Di will join late. She's busy with some guests, so but she will join. So let's see where she joins. Others are present.
Okay, then we proceed with the panel discussion. So stillbirth is an enormous yet overlooked tragedy. In the modern concept of obstetrics, especially when we are talking about safe motherhood, it is a kind of a failure if we're not able to give a live baby in the hands of the parents at the end of the healthy pregnancy. So it is a very, very tragic situation to be faced by the family, because a thing that should have brought so much of joy to them ends in a tragedy. So to discuss about the various aspects of stillbirth, I would like to ask Dr. Asha, what is stillbirth and how will you define stillbirth? Dr. Asha?
Yeah. Am I audible?
Yes, yes, you are.
For international comparison, the WHO defines stillbirth as a baby born with no signs of life at or beyond 28 weeks of gestation. It is diagnosed by absence of heartbeat. There is no heartbeat. There is no breathing movements. There is no pulsation in umbilical cord, and there is no movement of voluntary muscles. although the definition varies, previously it was varied from different gestational age, like 20 to 28 weeks, and the weight of the baby was considered like 500 grams to 1 kg. But now it is accepted that it is the beyond 28 or beyond 28 weeks of gestation, and all these features.
Yes, the features are that it should not be an induced termination of pregnancy, and after expulsion or extraction, the fetus should not be breathing or show any sign of life, such as beating of the heart, pulsation of the umbilical cord, or definite movement of voluntary muscles.
Yeah, no signs of life.
Yeah, the heartbeats need to be distinguished from the transient cardiac contraction, and respirations are to be distinguished from fleeting respiratory efforts or gasps. So based on what you said at the WHO definition for international comparability, because in various countries you have different, period of viability according to the level of care that they provide. So for international comparability, you are very correct in saying that about all what you said. So based on that, those criteria, Imrana, can you tell us what is the incidence of stillbirth in the world and in India?
And annually, an estimated 2.6 million stillbirth occurs worldwide. About 98% of the stillbirth occurs in low and middle income countries, with the 3/4 in sub-Saharan Africa and South Asia. As per this 2014 World Health Assembly, there were in 2015-16 neonatal deaths were at 22 per 1,000 live births. And in 2014, World Health Assembly endorsed a target of 12 or lesser live births per 1,000 in every country by 2030. The Government of India has developed a national newborn action plan, which include efforts to reduce stillbirth to less than 10 per 1,000 births by 2030. So it is 2.6 million and 22 per 1,000 live births.
Half of these, they occur intrapartum. Half of these deaths are occurring intrapartum. So that reflects the level of quality care that you're providing during labor. And as you correctly said, that most of them, almost 90% of these stillbirths are occurring in low middle income group or low income group countries and all. So this is the WHO fact sheet. And as we can see, most of the stillbirths are confined in these Saharan countries and in India and Southern Asian countries. When we look at India, we see that there is a belt from Rajasthan extending through Madhya Pradesh, Chhattisgarh, Odisha, which have the highest rates of stillbirth, and they need to be reduced. In India, we can say that the overall the stillbirth rate is 23, and about 1,622 babies are dying each day from stillbirth. So that is a huge amount. So it is a silent consequence crisis. So what are the consequences of stillbirth? Dr. Amita Sinha was supposed to answer this. You can answer. Go ahead, Dr. Imrana. What are the consequences of stillbirth on the family?
Or anybody can take the question.
What you can do. Is Dr. Supriya present?
No, she is not.
You
can answer this. What are the consequences of stillbirth on the family, on the doctor?
Consequences, it's a real emotional setback to the entire family, as they are connected to the patient, and it's really grieving entire. And there are certain because we need to track the patients further. There are a lot of recurrence risks associated with the stillbirth, because once a stillbirth, we have to be really taking that patient on for a preconceptional counseling, and we have to counsel the patient exactly for the next time, that before she embarks onto pregnancy, she has to be really meeting us. So it leads to a lot of maternal depression, financial crisis sometimes, and economic repercussions. And it is a kind of a stigma associated with the society. And still some stigmatization is really associated as it goes in our society, and is a kind of taboo. So we have to make her keep on really encouraging the patient, and sometimes it happens that we need to go for some antidepressant and psychosomatic drugs need to be initiated if she is not able to cope up with this loss?
The tragedy which is insufficiently addressed in the global agendas, policies, and funded programs. So, can anybody say what is ENAP? What is ENAP?
ENAP.
ENAP is every newborn action plan, as we have in India.
Okay.
That is
To
INAP.
bring down this to less than 10
rate
by
of stillbirth
2030.
to a single digit number. The WHO has said that it has set a target of 12 or fewer stillbirths per 1,000 total births in every country by 2030. By 2019,
I was not knowing by the name, but this is the target we knew. ENAP, newborn action plan. This is newborn action plan.
Every newborn action plan by WHO. And by 2019, most of the high income and the upper middle income countries had met this target, but many countries have not, especially the lower middle income countries. Even in the high income group countries, those vulnerable groups and ethnic minorities, they are the biggest sufferer of stillbirth. So Dr. Smita Singh, how will you classify stillbirth?
Okay.
Dr. Smita Singh.
Good evening. Although there are 80 classification systems known and devised for classification of this stillbirth, but as we commonly use, that depends on the gestational age group. That is early stillbirth or late stillbirth. Early stillbirth is at the gestation 20 to 27 week, and late is 28 week or more than 28 week gestation. And apart from this, there are other classification systems also depending upon the cause of stillbirth, like this ENCODE, RECODE, revised RECODE, ICD, and apart from this, also a classification system is there depending upon the anatomical location of the fetus, that is intrauterine, antepartum, intrapartum, etc.
Antepartum or intrapartum, depending upon the onset of whether the death occurred before or after the onset of labor. You can classify them broadly into antepartum or intrapartum stillbirth.
Yes, anatomical location.
What are the types of stillbirth?
Early and late.
Yes.
Early and late.
You also have macerated or fresh stillbirth.
Fresh, yes, yes.
Macerated stillbirth is?
In utero, the baby died.
More than 24 hours prior to delivery.
Yes, yes.
So the skin will be peeling off.
Yes. And
whereas the fresh stillbirth occurs during labor, after the onset of labor.
Yes.
So this is also called intrapartum death.
Partum death.
Yeah. How you distinguish the macerated stillbirth, and this one is a fresh stillbirth.
Yes.
So can you tell about the time of intrauterine death depending upon the grades of maceration?
Yes. If it is less than 8 hours, the reddened skin and parboiled skin is there. And if the fetus died more than 8 hours ago, then there is skin peeling, and there is extensive peeling and red serous effusion in chest and abdomen in 2 to 7 days. And liver is yellow brown and turbid in effusion is there if the fetus died more than 8 days ago.
So depending upon the time of death, you can have all these features. So Dr. Sangeeta, I think she's not there. So how will you diagnose stillbirth? Is Dr. Sangeeta there?
Anybody can take this question?
Yes. Can I answer?
Yes, yes.
Hello.
Hello,
Yes, am I audible?
Yeah,
yes, you are audible. Yeah, you are.
Am I audible?
Yes.
Yes, you are.
Am I audible?
Yes, you are audible.
Dr. Sangeeta is.
How will you diagnose stillbirth?
By first, we have to inquire. First, hello.
Yes, go ahead.
Dr. Sangeeta is speaking here.
Yeah, we
Hello.
can hear you.
Yeah,
Please go
listening to
ahead.
Yes,
Sangeeta,
ma'am.
please
Yes,
go
ma'am.
ahead. Please go
Actually,
ahead.
there was echo because of mic. Someone was speaking welcome speech on there.
Dr.
So
Sagita,
okay,
Go ahead.
okay, ma'am. How to
Dr.
diagnose?
Sagita,
First,
have
yes,
you
sir.
connected with 2 devices?
No, ma'am.
Then there should be no
Go
echo.
ahead. Okay, we go.
Actually, it's Dr. Santi Rai, ma'am, is there. So, welcome speech is going on there. So, from mic, I was not able to hear anything. So, I have just, I have sat outside the hall. So now I can talk. Am I audible right now? Hello.
Yes,
Dr.
you
Sangeeta,
are.
Yes, ma'am.
Please say that you are audible. Please go ahead.
By medical history, first of all, diagnosis is by medical history. All the things should be taken in care. That what is her age, what is her BMI, any hypertension, all the medical history like diabetes or hypertension. She
How do
is
you
suffering from
diagnose?
thyroid. Hello.
Just diagnose
Hello,
stillbirth.
diagnose stillbirth. I'm not
What are
asking
the
about
features
the
which will help
causes.
you to diagnose stillbirth? Whether patient has a dead baby or a live baby. Just you have to say this.
So from the history, she will tell that I have not perceiving any fetal movement since how many times or how long she will tell, and then we will handheld with handheld Doppler. A staff nurse or doctor who is available on the duty will search for FSH if it is not available, and if it is tertiary center or ultrasound is available at that center, even at secondary center, we can do immediately ultrasound if not possible, if it is holiday or Sunday. So if ultrasound is for next day, can be done immediately as soon as the ultrasound facility is available. So based on
Okay,
the
so based on the diagnosis requires real-time ultrasound, and diagnosis
So-
based on absence of fetal heart motion will be wrong in up to 20% of cases.
Yes,
Both
yes.
false positive and false negatives can occur.
So-
So a repeat ultrasound should be ordered. And sometimes in some certain cases like severe oligohydramnios, gross obesity, there you may require color Doppler
Yes,
for diagnosis.
but a Spalding sign is
what
a
is this
Spalding
typical
sign.
sign?
This is a
Yes.
Spalding sign, overlapping of cranial bones.
So in ultrasound in 100% of cases will tell you about the stillbirth. The obsolete X-ray abdomen that used to be taken done earlier with the classical sign of Robert's sign, that is appearance of gas shadows in 12 hours, Spalding sign, collapse of skull bones, which usually occurs 7 days later, Ball sign, that is the hyperflexion of the spine, helix sign, gas in the umbilical arteries, and crowding of rib shadow. These are all obsolete. This is just a crowding of ribs that can be seen in this X-ray. So this is how we diagnose stillbirth. So Dr. Tulika, can you throw a light on etiology, the broad etiologies?
Very good evening, everyone. Yes, ma'am. The etiology, broadly, it can be classified into maternal, fetal, and the placental conditions. When we look at when we consider the maternal conditions, there could be many maternal metabolic disorders or pregnancy-induced disorders like eclampsia, gestational diabetes, or if she could have any infection, or there could be autoimmune disorders. Nowadays, patients who have experienced the COVID-19 during the pregnancy, they have also reported a higher incidence of the stillbirth in their pregnancies. And when we there are other, if the pregnancy is continued for prolonged period, maternal trauma is there, and thrombophilic disorders, they should also be considered. In the fetal conditions, it could be a multiple gestation, it could be monochorionic pregnancies, which may present as a stillbirth, intrauterine fetal growth restrictions, or the small for gestational age babies, they also present as a stillbirth. If the baby is suffering from some congenital abnormalities like arteriovenous malformation, the baby is fine, but all of a sudden it undergoes the cardiac decompensation. If there is some genetic abnormalities, infection in the fetus like Torch group of infections, or the fetus is hydropic. The environmental condition, or we have classified as placental. It could be cord abruptio placentae, cord accidents, real true knot in the cord, vasa previa, or any kind of the placental insufficiency.
Yes, thank
So,
you.
Dr. Meenakshi, can you tell us about the record system?
Hello, I am audible, ma'am. Am I audible?
Yes,
Everyone is audible, so don't ask every time, am I audible? Everyone is audible and it's
The
clear.
record is the classification system as a new classification system, which depends on the relevant condition of fetus at the time of death. This system is very useful, particularly in low resource countries, because there we have less investigation required. Fetal autopsy is not must, and it classifies majority of cases of stillbirth in some categories. More than 85% cases of the stillbirths, the cause is classified. It is a hierarchical system of classification which starts from the fetal condition, which comes in group A, coming outward to a group D is umbilical cord, C placenta, D amniotic fluid, then uterus, mother, intrapartum trauma, and unclassified. So majority of the cases fall in some categories, and only 11 to 15% of the cases are classified in unclassified, where the other classification systems categorize more than 2/3 of the cases in unclassified. So it is very useful, particularly in
advantage of this record new system of classification. Can you just enumerate group A features? What are the
fetus? The first one is the lethal congenital anomaly. Second is infection, maybe acute, maybe chronic. Third is a non-immune hydrops. Fourth, isoimmunization, feto-maternal hemorrhage, fetal growth restrictions. And the second is the umbilical cord, in which umbilical cord prolapse, constriction or not, velamentous insertion, and others. Third is the placental conditions like abruptio previa, vasa previa, other insufficiency, and other causes. Whereas amniotic fluid, the commonest is infection, chorioamnitis, oligo, poly, and others. And then coming to the uterus, when uterine rupture, uterine anomalies, and others. And then after the uterus, then maternal medical condition like diabetes, thyroid disorders, essential hypertension, hypertensive diseases in pregnancy, lupus, cholestasis of pregnancy, drug misuse, and others. And after the maternal condition, there should be the intrapartum condition like intrapartum asphyxia, birth trauma, and then there's trauma which may be external, iatrogenic, and last one is unclassified.
Iatrogenic, especially like external cephalic version and all, when we're doing, sometimes the fetus
forceps ventus, etc.
So the group I is the unclassified, where either you do not have any relevant condition identified, or there is no information available. Because here we are trying to ask the patients and all, how did this happen and all. So it is a kind of survey. So they may not be knowing the exact cause of death. So in that condition, we categorize as no information available. So with the use of this record system of classification of stillbirth, we are able to identify the majority of the causes of stillbirth.
Yes, ma'am. More than 85% cases are recognized.
So Kavita, can you take forward?
Yeah. So Dr. Shreya Karan has joined. You are here?
She's there.
Okay.
Yes, she's there.
So can you explain what are the risk factors for stillbirth, Shreya?
Ma'am, risk factors can again be classified as maternal risk factors, fetal risk factors, and the maternal risk factors would be low socioeconomic status, older age, that is one of the major risk factors, age older than 35, consuming of any abusive substances like smoking, marijuana, and any illegal drugs, and any maternal condition like obesity. Again, like old age, obesity is one of the major risk factors for stillbirth. diabetes, again, one of the major risk factors, and high blood pressure, preeclampsia, eclampsia, including pre-existing hypertension. And maternal reproductive history also has a role here, never having given birth before, and elder primary gravidas, and previous stillbirth or small for gestational age infants, pregnancy with twins, triplets, or other multiple pregnancies, and also associated a lot with IVF pregnancies.
Yes, sure, you are right. Excessive use of all these drugs and even excessive use of coffee also. It can lead to sometimes severe IGR and can cause stillbirth. And another risk factor for stillbirth, next, fetal. So
Then
the fetal factors are.
The fetal factors include IUGR in the fetal.
And I think it had been already been explained that twin, triplet, congenital anomalies, all these can cause
IUGR, monochorionic pregnancies. Yeah.
So this is case. Anybody can take the question. A 29-year-old gravida 2, para 1, no para, 1 abortion with previous history cesarean section 3 years back at 34 weeks for high blood pressure. She presented this time at 37 weeks with complaints of loss of fetal movements for last 4 days. There is no history of any trauma, any bleeding per vaginum. She was a book case since 16 weeks of pregnancy, and she had normal regular ANC. Ultrasound scans were normal. All routine investigations were done and they were within the normal limits. She had received routine TT injection and was on folic acid, iron, calcium supplements, everything. So all these things were given, and these history, past family history, past history were not contributory. There were no any history of chronic illness or any substance use, any history of diabetes, hypertension. On examination, patient was of average health. There were no severe pallor, no jaundice, no dehydration, no cyanosis. Vital signs were within normal parameters. And during abdominal examination, there was financial incision, which was healthy. Fundal height was about 34 by 40. Cephalic presentation, fetal heart sound were absent. PV examination showed os 3 cm dilated, cervix long, posterior os, firmly os was closed, cervix was 3 cm long. There was no discharge. All other systems were normal. When ultrasound was done, it confirmed fetal death, and lacquer was less than for gestation days. So next. So Dr. Asha, can you tell us what could have led to stillbirth, and how should we break the news to the family and how to counsel? Because she had everything normal, all ANC done, every parameter was normal, and suddenly fetal heart sound is not seen, and how we can disclose it to the relatives and patient, and what should be what could be the cause of stillbirth in this case? Dr. Asha?
Yeah, cause of stillbirths are many. Although all investigations could be normal, but late IUGR may be there, and there are some other causes of the placental insufficiency that may cause a stillbirth. And first, the patient has come to the complaint of loss of fetal movement. Obviously, we have to auscultate, and after doing the ultrasonography, when we confirm, or if she has already confirmed, then to be rescan the patient if we confirm that it is a stillbirth or IUD, whatever. First of all, it is very important how to break the news, because it is a big shock for the obstetrician as well as for the patient and her family. And the stillbirth news should be given in a very calm and cool manner. First of all, we should be very, we should have very tender and loving care for the patient, because sometimes the family also says, she is negligent, she has not done proper investigation, or she is not following the things, this is because of her fault, or sometimes there are other reasons. But we should be sympathetic with the patient, and we should see all the history and examination, what could be the probable factor. If we know, we can explain. If we don't know, then we should try to know what are the other reasons, and we should document what are the features, and we should tell all this to the patient. And
we should involve the husband and the family members.
There should be some family members, and for doctors also there should be 2 or 3 persons, because sometimes patient or her attendance becomes very bad. And the news will be in a very calm and cool manner. We should
Yes.
be emotionally
Yeah.
attached, and
We should discuss the investigation.
Yeah, we
with
have
them.
to discuss that
and
many
we
a
have to
times
tell
the
them.
cause remains unknown.
Yeah, unknown.
Many a times
In
everything
this
is normal,
case,
but still cause
At the
remains
Well, in
same
this
unknown.
case, there was, I mean, no identifiable cause of death could be
Yeah, what
identified.
is the mode of treatment? In which mode of treatment we should go? What investigation we should do further, and how she could come for the further follow up for the in this time after 6 weeks or before if she wants to conceive, that at least what period she should take at that time. All these
Okay,
things
that
we
is
should.
okay. That is there. Okay.
Yeah.
So,
So,
and what about the psychological management?
Yeah. Psychological
Because
management.
this comes as a big shock to the patient.
Yeah, yeah.
You have to
we
be.
can counsel, though you have done all the things and you are aware, we also doing each and everything, but there are some causes which are unexplained. So this happens, but it
You
is
have to
not
tell this to the
actually,
patient.
Doppler
in every
velocimetry,
pregnancy. Yeah, in
Doppler
future
velocimetry
pregnancy,
should
yeah.
be done because many a times it comes, there is reversal of flow or absent and diastolic flow, which not done still in many areas and many centers. But I think it should have been done, and maybe it would have tell that the patient, the baby is going to be have severe IGR and asphyxia and may go into death for a,
And we
within
should
hours
also,
or within days.
and we should
So-
also consider that there may be some causes that are recurrent or modifiable factors. There are some factors that are not recurrent. So it is not
Yes.
the always possibility that she will again have stillbirth. So
yeah,
this
we
all
have to
considered.
explain that there is some fetal reserve also, because
Yeah.
same condition, same situation, many fetuses survive, but many do not survive. So just we
Yeah.
have to be sympathetic to the attendants as well as to the patient. We have not to disclose directly to the patient. In fact, we should discuss with the relatives and her husband. Thereafter, we have to disclose them. So this the situation which we faced more or less once or twice in a month. So we have to be very patient in talking to them. So what are the investigation that should be done in this case, Dr. Imrana?
Yeah,
What
as,
investigation?
routine blood biochemistry we should be doing as such, and the investigation we need to do is to regarding the maternal well-being, then the ascertaining the cause of death, and to assess the possibility of and further complications. So complete blood count to look for any evidence of maternal disorder like infection. Not in this case, but as such, glucose screening, HB1AC, here is quite a pointer towards APLA antibodies, because it seems to be a placental dysfunction. So very importantly related to this very case can be a lupus anticoagulant, anticardiolipine, anti-beta 2 glycoprotein 1 antibody titers, immunoglobulin IgG and IgM to exclude antiphospholipid antibody syndrome, especially in the presence of growth restriction or severe preeclampsia. And routine testing of inherited thrombophilias is not recommended. Then apart from that, the Klihor-Betke test is important to assess to maternal hemorrhage. Before that, we have to go for a glucose screen, direct Coombs test to exclude red cell elimination. Then those
Very important, the coagulation profile, because the risk of DIC is there with the old.
That has to be always incorporated in case of a stillbirth, because of lot of risk of DIC. As regards expected management also, which we should go ahead, we can go ahead with the deranged parameters or coagulation profile, because we can take time by time for the normal vaginal delivery. But if the coagulation profiles are abnormal, then in that case we can always counsel the patients regarding not only the operatic since it is abnormal, then we have to go for that. But this case is a quite importantly an APLA, feto-maternal hemorrhage, is sometimes usually occurs not only in the Klihor-Betke is important to assess the fetal cells in the maternal circulation and detecting a large maternal hemorrhage may occur.
Has Dr. Amita joined?
And important Dopplers are
I am not seeing her.
umbilical artery Doppler, cerebral artery before.
Okay,
Scans are very important for looking at the lichens before the patient, because we have to follow with the serial growth scans and all the Doppler velocities and CPR, cerebroplacental ratios, all these things. And
that was there if you had.
I think you have explained all the points, Imrana. And one of the important is obstetric cholestasis. This can also lead to stillbirth. So liver enzymes should be tested. Even it can lead to IUD. So next. So these things and if we have to rule out the infection also, because many times patient is positive for certain viral or even certain
megalovirus, parvovirus, and Zika is important. So a TOT screen can be done for anti-Rola antibodies, SLE, renal lupus. Karyotype is not a very great pointer. Parental more than that. This is a
if the fetus shows translocation or abnormality, or there is recurrent loss, then you go in for
actually the patient has one healthy baby, na? No, she had one abortion. She had one abortion.
This is actually general. General, what is the investigation that you'll order?
But you need
particularly for this particular case.
Very, very important, which is more reflecting any, because disorders and aneuploidies are more important, and the first trimester losses are more related to balanced translocation. Unbalanced, we can carry for the stillbirths, it may account for. So aneuploidy and or all these, so entire gamut of investigations are there, but accordingly, depending on the case, we have to be more concerned with particular investigations, and we can leave unnecessary ones. However, the routine ones like liver profile, glucose, and HB1 and fasting PP, random indirect wombs, all these can serologic for syphilis can always be incorporated. And
okay, Dr. Rekha madam is there. She can give any expert comment. And madam, are you there? And another thing, will you like to go for postpartum examination of the baby, Imrana? Will you request parents that they should give the baby for postpartum examination?
Yeah, if autopsy is there, it's best, because it will guide us for the future pregnancy.
It's my question,
Smita
Dr.
is there,
Imrana.
na? Yeah, Smita will explain.
Yeah,
Smita, okay.
Yes, yes, ma'am. Autopsy or post-mortem, as we know, is able to diagnose the cause of death in almost 40 to 45% cases. So the decision of autopsy is done, and a team is made of obstetrician, the midwife, the perinatal pathologist, and the expert of fetal and maternal medicine. So, and this autopsy cannot be forced on the parents. It is an informed consent, both verbal and written. We do what we will do, what will be the procedures, what cells will be taken, what tissues will be taken, and what we will do to that tissue. All these are informed in written also, and the parents are advised to go for the autopsy. Before that, and they can take the keepsake items of the fetus, like the footprints, handprints, and the photos, the clothing, blankets, all these are taken. If the mother wants to take the baby in her lap, that also is promoted before autopsy. And then the proper process is carried out in the protocol, in a definite protocol manner. Autopsy is started with both external and internal. The external appearance of the baby weight, its measurements, head circumference, all are taken. And then the internal, the fetal skin, deep skin, the fascia lata, patellar tissue, etc. are taken. Also the placenta and the membranes are looked for. The internal organs like intracardiac aspiration can also be taken, but and further consent is taken, and other organs like thymus, lungs are also taken for autopsy. This cases are yes, I have almost
Yeah, you have
covered the
explained all the
cases.
points. So it's you are really it's I think everyone has understood that the importance of autopsy, but patients are so distressed that they may not offer, but still we have to
Yes,
counsel them.
yes.
Yeah,
Apart from
yeah.
autopsy, the supportive non-invasive methods are also there to diagnose, like this X-ray and USG, even MRI are also done. But these are just an adjunct and cannot be the supplement for autopsy.
Can explain to the
X-ray can
parents
be
that
done.
needed
Yeah.
to stop such things repeating in future pregnancies.
Yes,
Yeah,
yes.
just we
they
have
must
to
be
counsel
counseled.
them so that future pregnancy is safe and we can diagnose and we can offer the
main-
treatment accordingly. So,
yes.
so Dr. Sangeeta there, Sangeeta,
Yes, ma'am.
so in this case, which is a case of previous cesarean, how will you plan for delivery?
Ma'am, after
37,
proper
yeah, 37
after
weeks of pregnancy.
proper counseling, I will admit the patient, and since it is since the cervix is 3 centimeter dilated, but
Cervix is not dilated, os is closed. Cervix is long and os is closed. It's not dilated.
So Bishop
This case
score
previous
is less than 6. So
Yeah,
we
less than
have
6.
to induce. We have to induce with either with medical drugs or some surgical management by foliage or
He has a
anything.
scar. So will you like to give any gel or any prostaglandin? Because he has a previous scar.
So
he is a case of previous cesarean.
So I have to induce with PG even
foliage,
gel.
yeah, or foliage catheter we can insert. It will
Yes,
also dilate, and depending upon whether she needs immediate delivery or what is the condition of the blood pressure or other things, whether she is going into sepsis. So everything we have to see, and if it's urgent, then although vaginal delivery is preferred, but if there is not progress or if there is any history or anything, any point that it regards immediate delivery, then we can proceed for cesarean, although it should not be done in first sitting. She has scar, but we can wait and we can prefer vaginal delivery. So,
Actually, any action should be only taken after assessing the individual case. It depends upon the individual case, the place where you are doing and the obstetrician.
Facilities available.
So actually, you have to assess whether you can do it in which way. And that is the way you should prefer. So somebody is writing that you can give mifepristone, but priming the cervix initially will be good. So do it after that. In any case, so in any induction, priming the cervix will be good.
I think mechanical method is
Mechanical method, that is what I'm meaning.
better
But
for dilating the
mechanical
cervix
method
or
is very
induction.
good because after that only, because if you give something systemically, then you have no control. But in the mechanical method, you have control. So it should be under control.
And along with the
actually in general delivery, not in this particular case, but in general, the delivery must be planned immediately if there is preeclampsia, abruption, placenta previa, sepsis, or rupture of
That is what I meant by individualized.
Yeah,
So in
it
all
should
other
be
conditions,
individualized. Yeah,
so in all
depending
other
upon the condition
conditions,
of the mother.
We should prefer vaginal delivery, and we may wait for the onset of labor. The method and timing of delivery will after stillbirth will depend on the gestational age at which the death occurred, and the maternal obstetric history and maternal preference. So before 28 weeks of gestation, vaginal misoprostol appears to be the most efficient method of induction, regardless of the cervical Bishop score. Although high-dose oxytocin infusion also is an acceptable choice, both vaginal and oral misoprostol
अपने से लेते रहना ना, एक दो फोटो ले लो.
uterine evacuation within 48 hours. Before for 28 hours of gestation, typical dosage is 400 to 600 micrograms vaginally every 3 to 6 hours. And after 28 weeks of gestation, the induction of labor should be managed according to the obstetric protocol. those women who have a history of previous hysterectomy, cervical ripening with a transcervical Foley catheter has been associated with uterine rupture rate, which is comparable to the spontaneous labor. And so this is a useful and helpful adjunct in patients with an unfavorable cervical examination. Those patients with one previous low transfer cesarean delivery, trial of labor remains the favorable option, and delivery plan should be individualized based on the individual circumstances and patient preference. Cesarean delivery for fetal demise should be reserved for unusual circumstances like those with an increased risk of uterine rupture or
somebody has written mifepristone. Has he used? Because I have not used mifepristone in cases of scar. So the person who is writing, whether she has used.
Madam, I am Dr. Prachi Singh. I have used mifepristone in cesarean induction method.
Okay, so what the dose?
I have also used.
So Prachi, what is the dose?
This is recommended by AOGSBJ. The nice
400.
200
No,
oral.
I have used 400 also, and I've not had any problem.
Yeah,
Actually,
Kavita
Devi, we are
200
using
milligram. 200 milligram, 8 hourly. 8 hourly we can use.
Okay. And it has no any problem with the scar,
no? Because it is not a prostaglandin, so it does not cause uterine contraction as such. It just causes the uterine the cervical ripe.
Archana, have you used this molecule?
Yes, we are using it. Actually, we give 200 milligram or sometimes 400 milligram also. And then we start with the Foley's catheter after 24 hours or maybe after 36 hours.
Good. So this is a good message. Take home message that we can use mifepristone.
I think it's a single dose. Mifepristone is a single
Yeah,
dose.
it is single dose only. Yes, of course, single dose.
Only
Yes, it's
single.
not,
In the beginning, 200
Yes.
milligram as a single dose.
Just like we are using it for medical combination of medical method of abortion. That's just like that.
Okay, Dr. Tulika. So how you will take care of the mother after delivery, whether it's vaginal cesarean? So what should be the purpose of postpartum care in this case?
In the postnatal care should be focused in the two areas. One is the physical area of the mother where she is recovering from the labor and whatever the medical disorders she may be suffering from. And also there should be a lactational suppression plan should be installed in the given to the patient. And another thing is her psychological support. The bereavement counseling should be given to the patient these cases, so that they can evolve from their psychological trauma.
Thank you so much. So, Dr. Meenakshi, what advice will you give to the woman for her next pregnancy? Because she has lost this baby. First baby has also been lost. So, what advice you will give? Because they are very upset. The family is very upset. The woman is very upset. How we will advise them?
First, we should know that what was the cause of the previous stillbirth, and if a woman is having stillbirth.
I'm sorry to say the previous birth was live birth. It was preterm birth, but it was a live birth. This particular pregnancy ended in stillbirth.
Yes, yes. Oh, any woman having a stillbirth are at 5 times greater risk of stillbirth in her next pregnancy. So preconceptional counseling is very essential. And ideal interconceptional period is not defined in this particular case because it depends upon the maternal age also. And patients should be advised to lose weight if she is obese, and other medical conditions like diabetes, hypertension, thyroidism. Patients should be advised to that all the medical conditions should be managed to their optimum level, blood sugar and blood pressure. If she is having cholestasis, all should be optimized before planning the next pregnancy. And so should take a 3-month folic acid in the preconceptional period, and in karyotyping if she had any genetic problem was seen in the stillbirth baby, or there were little suspicion of that thing.
Will you like to give echosprin in these cases? Though there is no clear history of how the baby is lost, but I think prescribing echosprin is a very good thing, no? Once the patient considers, because it will not cause any harm.
Case, Kavita.
Yes.
Move on to the second case.
Okay, so this patient, 27-year-old female, gravida 2, para
Dr. Leena,
0,
you will have to
abortion
wrap up
1.
fast. Dr. Leena, you will have to wrap up fast because we are well past the time. We have another panel also.
Okay. So just the patient was in late second trimester pregnancy. Patient was not given any prophylactic anti-immunoglobulin therapy after the abortion. So investigation were normal. Blood group was B negative. Indirect circumstance was positive. Serology for TORCH were negative, both for the IgG and IgM antibodies. Next slide. Yeah. Antenatal ultrasound reveal bilateral pleural effusion, ascites, increased amniotic fluid volume, placentomegaly, elevated fixed systolic velocity measured in the middle cerebral artery, and which is associated with 100% sensitivity in predicting moderate to severe anemia. So variable parietal diameter and abdominal circumference large for gestational age, increased scalp thickness, increased abdominal skin thickness. So these are the ultrasound findings. Next. So these are the picture of the ultrasound which we have discussed already. So how we will plan next? So there is
around the
thick
fetal
scalp.
head, then fluid around the lungs, and ascites. Placenta was large, and this is a typical picture of high peak systolic velocity that we find in anemia in the middle cerebral arteries. This is a typical picture we find in Rh negative fetuses. So Shreya, what is the diagnosis? Shreya?
Is it clear cut? Shreya, are you there?
Yes, this baby is presenting with the feature of immune hydrops fetalis, and all the findings are there in the ultrasound, even though the blood group is not mentioned, but the
blood group was mentioned. It is B negative.
B negative. Patient is B negative, na? Indirect circumstance is positive.
She was not given anti-D in the previous abortion, after a previous abortion. And her indirect Coombs test was also positive. So she was sensitized. So she was counseled regarding the prognosis, and she was referred to the higher center for intrauterine exchange transfusion and further management. But she did not go there. Instead, after 5 days, she comes back with complaints of loss of fetal movement since last 2 days. And ultrasound confirmed fetal demise. So what needs to be done, Dr. Asha?
Asha, are you there?
Anybody can take the test. What needs to be done now?
Prachi can take. Imrana?
Ma'am, the patient is already isoimmunized. I don't think the routine obstetric, I'm not expert in the routine obstetric care, but when she was RX non-immunized, then we could have gone for all those sorts of precaution one takes while delivering the baby. She is already RH isoimmunized. The counseling regarding the future pregnancy. In the future pregnancy, we should start the monitoring pregnancy with middle cerebral artery Doppler as early as 16 weeks of gestation, and we should counsel her regarding the need of intrauterine transfusion in the subsequent pregnancies and in the subsequent all the pregnancies.
Yes.
And she may need multiple transfusions.
Yes, you're right.
Facilities are not available in that particular area. She should be shifted to a center which has all these facilities and fetal medicine center and all for better outcome of her next pregnancy, because she's already sensitized. There's no role of anti-D or anything like that. And what are the particular precautions which one must take in delivery of Rh negative woman? Imrana?
Anybody can take?
Shreya, you can take this.
Ma'am, whatever I can remember from my
minimal
PG
handling should be there. Yeah.
Yes.
Minimal handling of instrumentation in case of quick early clamping of the cord should be there.
Yes.
Regarding Rh negative patient, if she is non-immunized, anti-D must be given at the time of diagnosis of stillbirth. So when we diagnose stillbirth,
she's immunized. She's already immunized.
Yeah. So
if she's sensitized, not immunized, sensitized. So
if you sensitized, then it doesn't
already
really matter.
Sensitized. So there's no role of anti-D in her case.
Yes, no role. Yeah.
But precaution should be taken to decrease the further exchange. So early clamping.
Yes, you are quite correct, Dr.
No,
Shreya.
no, Dr. Lina, this is totally wrong. The
Why,
patient
madam?
has got very high level of anti-D in her blood. There is no need to give more anti-D from outside.
No, I'm not saying. That is what I'm saying, madam. That is what I'm saying. That there is no need. She's already sensitized, so there's no need to give her any
Anti-D is
anti-D.
not going to do any.
But you should prevent further exchange,
That-
like further.
That is what I am saying, madam.
Already
There
she
is
has got so much of anti-D.
She has so much of antibodies. She's already sensitized. So no role of anti-D here. We need not. We just have to counsel her that in next pregnancy, future pregnancy, she should come early for booking, and she should preferably be in a center with all fetal medicine facilities available. She should go to such a
And if possible, the heterozygosity of the partner should be considered.
also be done. Yes,
If she has got both the arms with present anti-D, then present D, then there are no chances of unimmunized pregnancy. There are no chances of IS negative babies in the future. So each and every pregnancy she is going to have this problem. So as you said, she should be consulting higher center.
Transfer to a place of higher center where fetal medicine facilities are available.
Dr. Leena, Dr. Kavita, and Dr. Rekha Jha, who are the experts. There has been one question. I'm sorry to interrupt your panel, but there is one question from Dr. Kavita Priya, and which says, with one previous CSX and a concomitant low placenta abutting onto the internal loss, how safe is it to induce at 20 weeks in a case of stillbirth?
20 weeks. Hello?
Yeah, see the case of previous cesarean and placenta is low lying.
Yeah.
Then it's
Yes, so-
difficult to induce. In that case, I think it's better to go for cesarean section. That will be better. If the placenta is
So we
abutting
can-
on the
Can try misoprostol.
As we were
for
discussing,
misoprostol for
as we were
cervical
also
ripening.
discussing, okay, Lena, you can speak. It's okay.
I said-
Rekha madam, you speak. Rekha madam, you are.
I was telling that earlier we discussed that mifepristone 200 milligram is being used in SKMCH.
Cervical ripening,
And
yes.
Archana also said that yes, it is RCOG guidelines. So just now I just read it that yes, RCOG guidelines is that 200 is safe, not more than 200, but you can give 100 also, 7 hourly, and 25 to 50 mg can also be given at longer intervals to induce this. And for this question that we are discussing just now, in this case, whether it is safe or not, if the placenta is low lying and all that, I think it is safe. It is always depends upon the operator. That is what I think. So I think it is safe. It is if it is in safe hands. And I will ask Anita madam, she is also here. Will she prefer it to induce it, or will she go for cesarean?
I will not go for cesarean section. That will be my
I will
last
also not
option
go
to
for
do.
cesarean.
Cesarean is the last
First, I will go for a good ultrasound examination, whether
Yes.
she is a case of placenta accreta syndrome or is it a simple low-lying placenta.
Yes.
That makes a huge lot of difference.
Yes.
Even if she is a case of minor form of PASS syndrome, I will not go for cesarean section. I will give her mifepristone, not misoprostol. I will give her mifepristone only, and I will wait for the vascularity to decrease.
Yes.
As the baby has already died, the vascularity is going to decrease and the placenta is going to shrink within few hours and days. And the bleeding is going to be reduced. And then I will induce her with, as we have discussed, mifepristone. And after mifepristone, of course, I'll be ready with 2 to 3 units of blood available to me.
Yes.
So that if emergency arises, I will go immediately for cesarean section or opening the abdomen. But I will induce her with very low dose of misoprostol. Say you can give either 25 or 15 microgram, 25 microgram of misoprostol only, and that also at the interval of at least 6 hours. And in my experience, in majority of the cases, patients go into labor with only 1 dose of misoprostol after mifepristone. And she will deliver and she will expel out the placenta also if it is not a case of PASS.
Thank you, madam. Yes, this is
So
what
now-
I also think is correct.
Now we are dealing with a woman with a history of stillbirth. So what will be the approach in a woman with a history of stillbirth? Dr.
Leena, will you wind up, please? Because another panel is waiting.
Yeah, panel is
And
there.
your
This one
time is
is-
already up. You have discussed two very good cases, and there has been such a beautiful discussion.
Very important aspect you are missing. How you will handle the crowd and protect yourself.
We will discuss it, madam,
Most
in the
important.
next program. We should not do injustice to the people who are waiting for the diabetes panel. So we should better start with the diabetes panel now. That is high time.
Yes, yes. Thank
Okay,
you,
thank you,
everyone.
madam.
Thank you, everyone.
Thank you, madam.
for
Thank you for
wonderful-
your
Thank you,
inputs.
ma'am.
Thank you, all the panelists.
Yes,
Thank
before
you, ma'am, for the
winding up,
opportunity.
one more thing I would like to just add that we were discussing velocimetry of the
Doppler velocimetry, yes.
When should it be started and what is the best time to do it? At how many weeks?
18 weeks.
Huh?
18 weeks.
No.
22 to 24 weeks.
24
and
weeks.
in most of the cases at 32 weeks. That is the answer.
See, it is recommended if your indirect Coombs test is positive. If your indirect Coombs test is positive, start your Doppler velocimetry from 24 weeks. Because below 24 weeks, anyway, this what Dr. Mandakini Pradhan told me.
Now let us wind up.
Give much information and the
Thank you,
comment.
everyone. Thank
Go
you,
to
everyone.
the
Scan is
for this
also very
wonderful panel.
important because
We need to wind up
NP
now.
scan also we
We'll
can
have another panel on.
Okay, okay, ma'am.
Yes, this
Thank
panel
you
was
so much.
very
Thank
interactive.
you.
Very interactive.
Thank you all the experts and all the panelists, and thank you once again organizers for giving us the opportunity.
Thank you, organizers, and thank you all the panelists.
I will stop sharing
expert
now.
Rekha madam, Anita madam. Yeah.
Yes, thank you, experts, moderators, and panelists. Thank you,
Thank
everyone,
you.
and
Thank
the
you,
esteemed faculty, the faculties who joined in and made it all the more interesting. Thank you so much. I would quickly like to move over to the next session, and for that, I would like to invite Dr. Alka Tiwari. Alka,
Thank you,
please
Divya.
come and take over. Huh?
Thank you, Divya. Good evening, esteemed guests. Welcome to panel discussion on very important topic on GDM. As GDM is the most common medical disorders of pregnancy. So we have dynamic, talented moderators, Dr. Professor Abha Rani Sinha ma'am, who is HOD and Professor of SKMCH Muzaffarpur. Ma'am is Treasurer, National ISOPAV. Ma'am was ex-president of Patna.
It's enough. It's enough, Alka. I think it's enough.
Okay, ma'am. You are my teacher also. Another co-moderator is welcome, ma'am. Another
Thank you.
co-moderator is Archana Kumari, who is professor in RAIMS, who is my batchmate also. She is very active, dynamic,
that would
and
suffice.
talented.
I'm
Who is
your
my-
batchmate. That's all.
Welcome, Archana.
Because we are already late.
Yeah, we are excited to have two experts on GDM. This will be a great opportunity for us to learn and grow towards better maternal and fetal
Good evening,
outcomes.
Archana Jha, ma'am.
We have
Good
Dr. Archana Jha ma'am and Dr. Pratibha Singh ma'am. Dr. Pratibha Singh ma'am is professor and director and senior consultant of Healing Touch Hospital, Bhagalpur. She is chairperson of IAEC. Madam has contributed many chapters in
Dr.
FOXI
Pratibha
and
ma'am has sent her regrets. She won't be joining actually.
okay, she is not joining. Okay, then we have expert Dr. Archana Jha ma'am is very senior OBGY consultant of Bhagalpur. Ma'am is live member of IMA, IMS, ISOPAV, IAG and Subhasi. Ma'am has very special interest in high-risk pregnancy and contraception, infertility, and ma'am is involved in many social welfare programs. We are thrilled to invite wonderful panelist for this, Dr. Apurva Datta. He's young, dynamic, active gynecologist of Dhanbad. He is National Coordinator of Public Awareness, FOXI Program and Sexual Medicine Committee. Dr. Anjum Mariam Siddiqui is Senior OBGY Consultant and ex-Senior Resident of Kolkata Medical College. Welcome, Dr. Imrana
Give me this
Dhanbad,
opportunity.
Director
Yeah.
and Fertility Specialist. Dr. Geeta Rani ma'am, who is director of Rani Women's Hospital, Bhagalpur, and was assistant professor of Bhagalpur Medical College. Welcome, ma'am. Dr. Prachi Singh is consultant and IVF specialist at Ashirwad IVF Center, Muzaffarpur. She has started first IVF clinic at North Bihar in 2013. We have Dr. Rupam Singh ma'am, who is Senior OBGY Consultant and ex-HOD of Bokaro General Hospital. Ma'am is very famous endoscopic and urogynecological gynecology surgeon of Bokaro. Welcome, ma'am. Dr. Ranjana Jha ma'am is Senior OBGY Consultant of Katihar and was Associate Professor of Mahatma Gandhi Medical College of Katihar. Welcome, ma'am. And the last but not least is Dr. Shudha Jha ma'am, who is Senior OBGY Consultant of Sadar Hospital, Sitamarhi. Ma'am is very active participants of many CME and workshops. So welcome all the panelists, and please Archana and Ava ma'am start your panel.
Okay, thank you, Dr. Alka, for introducing us, and I welcome all of you to the panel today. And I'm trying to share the screen. If I'm not able to do so, then I think Archana will be doing it. Let me see if I can do it. So we all know that hyperglycemia in pregnancy is one of the very important conditions, and it's so common because we all know that India is the capital of diabetes. And so when we see the pregnant women, I think most of us have the experience. Is the screen visible, Archana?
Yes, screen is visible.
No, ma'am. No, ma'am. No, ma'am.
Slides are not visible. Slides are not.
Your slides are not visible. It's just showing your front. Your front screen is showing. Your front screen is showing.
I think the is it showing?
You have to click slide, madam. Whichever slide.
Click on that particular.
It is stuck on one point.
Okay. Is it seen now?
No, ma'am.
Please stop sharing.
No, ma'am. Stop sharing. Ma'am, stop sharing.
A list of contents of your computer.
Okay, in my laptop I can see. So Archana, you please share.
Yeah, I will.
Maybe I'm having some problem with my net connection.
Yes, I am trying to share.
Stop sharing, Ava madam.
Yeah, I have stopped perhaps.
No, she stopped. She stopped. She stopped.
I've stopped.
Ava ma'am, first of all, just open that presentation on your laptop.
Yeah,
Minimize Zoom.
I have done it. I don't know why it's not opening. I have done it, but why is it not happening this time?
No problem, Archana, you will start sharing.
I've asked Archana to share. Let her share.
Yes, I am doing that. I'm also having some problem.
There's some problem. Do we have the permission to share?
Yes, sir.
Yes, ma'am. Yes, ma'am. Yes, ma'am. Yes, ma'am.
Sure.
All people on the speaker link have permission to share.
Okay.
It's showing. It's showing that Dr. Amar.
Yeah. So I.
Yes, ma'am. Yeah.
Now?
No, it's going off.
Yeah, now.
Archana,
I think now it will be there.
Yes.
Yeah.
Now it's coming, ma'am.
It's coming now. It's coming.
Yeah, ma'am. Yeah.
Okay. Thank you. Sorry for the.
Just make it full screen.
Yeah, I'm making it full screen. No problem. So sorry for the delay. So so welcome all of you to the panel on gestational diabetes mellitus. We are having a very simple panel. We are going to discuss the common things, the common problems which occur in day-to-day practice. And for this, we have our expert, Dr. Archana Jha. Unfortunately, Dr. Pratibha Singh, she could not join us because of she's in a train and it's difficult for her to connect. And along with me, I have Dr. Archana Kumari, a very talented co-moderator. And the panelists are Dr. Geeta Rani, Dr. Ranjana Jha, Dr. Sudha Jha, Dr. Imrana Rahman, Dr. Prachi Singh, Dr. Rupam, Dr. Apurva, and Dr. Anjum. And we all look forward for a very fruitful discussion. As I said earlier, hyperglycemia is one of the most common medical conditions women encounter during pregnancy. And we need to discuss it because it is one of the leading cause of maternal mortality, maternal morbidity, perinatal and neonatal morbidity, and also associated with long-term complications. And also hyperglycemia is a teratogen because it has detrimental effects on fetal heart, kidney, musculoskeletal, and CNS. And we all know that these days, Everybody is discussing non-communicable.
Slides are not moving, I think.
And also not full screen.
It's
Oh
full
my.
screen, but not moving.
It is not full screen.
It's moving?
No.
No, absolutely.
What is the problem today? I don't know.
Ma'am, just double click on your slide. Just double click on your slide.
Now?
Advanced.
No.
But it is visible now.
Is
Ma'am,
this
you need to stop share once again, ma'am?
okay?
While
Sure.
sharing, please click on the screen icon, ma'am. Don't click on the PPT, ma'am.
Okay.
Screen icon.
Shared screen, na?
Share screen, then screen.
Okay, then screen and then again share.
Yes,
Now I understand. This was the problem. Yeah.
Now you can go to the slide share, ma'am.
Yeah, is it visible now?
Yes,
Yeah.
just visible, but
Page
slide-
only.
Okay, so now we need to discuss NCDs because we all know that these days NCDs, they are a much talked about thing. Even Foxy has come out with a committee for NCD. So non-communicable diseases are important because they are programmed and imprinted during pregnancy, and diabetes is one of these most important NSD. Quickly, we move on to the case 1. And is Dr. Geeta Rani there?
Yes, ma'am.
Yes, so this case is for you, Dr. Geeta. She's a
Ma'am, your
newly...
slides are
Your
slides are
not
not
moving, Abhadi.
Or is it full screen?
It's not visible,
I
ma'am.
know, I don't know what is happening. So Archana, you please try.
Okay, let
Archana,
me try then.
mail the slides to me. Mail the slides
I
to
am
me.
doing that. I am doing that.
आभा मैडम, आपका जो शेयर स्क्रीन नीचे लिखा हुआ है ना,
हाँ जी,
उसको एक बार उसको क्लिक करिए ना, आ जाएगा। शेयर स्क्रीन करिए।
वो तो दिखा रहा है कि योर स्क्रीनिंग, योर स्क्रीन शेयरिंग, योर लाइव सब दिखा रहा है।
कोई बात नहीं मैम, तब तक आप क्वेश्चन पूछिए और हम
क्वेश्चन पूछिए मैडम। क्वेश्चन तो है ना लिखा हुआ,
have
पूछिए।
the slides. Archana, do you not have the slides?
I will just try
अर्चना
to do
भेज रही है, अर्चना भेज रही है उसको।
मैंने भेज दिया, तब तक मैं ट्राई करती हूँ ना।
तुम्हारा भी नहीं हो पा रहा है।
पता नहीं।
ट्राई करती हूँ।
Slides are not moving.
So let's take the case. Geeta, can you hear me?
Yes, ma'am.
Okay, she is a newly married couple. She presents to OPD. She is 29-year-old and has missed her period. Her urinary pregnancy test is positive, but she complains of pain, abdomen, and bleeding per vagina. You have advised her rest, and during the course of her investigations, you get a RBS of 314 milligram per DL, and she eventually aborts. Now, what is your diagnosis and what pre-pregnancy optimization will you do?
Ma'am, this is a case of miscarriage, and which occurred due to pre-existing diabetes, as her blood sugar is so much raised in the first visit, and for the next pregnancy, I would like to advise her for the preconception counseling and the care, the importance of it.
So 1 minute. How do you define GDM, Geeta?
Gestational diabetes, that patient is
Can I try once? अगर आप stop करेंगे share तो?
हाँ, sure, हम
ma'am,
stop कर देते हैं।
before conceiving, before pregnancy, the pre-pregnancy level of the blood sugar is normal, and she develops diabetes, that is the fasting blood sugar.
We don't know the pre-pregnancy level because the classical definition is any carbohydrate intolerance which is diagnosed for the first time during pregnancy. But in this case,
after 20 weeks.
Why? Yes. This case, you have rightly diagnosed it as a case of diabetes in pregnancy. Why? Because her initial values were more than 200. If we look at the recent FIGO classification, they have classified into one is that is diabetes in pregnancy, which can be type 1, type 2, that is pre-gestational. And the other is depending upon the value of blood sugar, that is after OGCT. So if her value is more than 200, it is a case of diabetes because the consequences will be different. If it is a simple case of GDM, that will require less of monitoring. But if she is a case of diabetes in pregnancy, that will require more of monitoring. So the diagnosis here right away comes as diabetes in pregnancy, which you have rightly diagnosed. Now, now as she has aborted, now what preconceptional advice you like to give her?
First thing is to make her understand the importance of glycemic control, and she should be counseled that if the glycemic control is good before pregnancy and during pregnancy, then the risk of miscarriage, stillbirth, congenital malformations, and neonatal death all will decrease. And so for the next pregnancy, optimization of the blood sugar is very important before conceiving. And if the glycosylated hemoglobin level is very high, like more than 10%, then
Ma'am, stop screen sharing, then I start screen.
Next.
Even the blood and the weight is also important.
Yes. Now let Geeta speak. Then I come to you, Imrana. Let Geeta speak. Yes.
The importance of preconception counseling and the advice that she should be counseled, the importance of glycemic control, that if she has good glycemic control before and during pregnancy, in the next conception, then there will be reduced risk for the miscarriage, stillbirth, congenital malformations, and neonatal death. And if the glycosylated hemoglobin HbA1c is very high, if it is more than 10%, then the patient should be advised to continue contraception till the desired level of glycosylated hemoglobin is achieved, and the desired level is less than 6.5%.
Okay.
And for those who have type 2 diabetes and along with obesity, they should be advised lifestyle management, that is weight control, dietetic management, along with the exercise. And the target for the blood sugar level is
okay, target will be doing it later on, Geeta, but the most important point is, since the initial blood sugar levels are very high, we have to check a renal function test, and also we have to do a retinal assessment.
Retinal and renal assessment should be done, and she should be started on drugs, which includes oral hypoglycemic drugs and insulin. Insulin is the preferred drug, and among out of the insulin also, it is the isofen insulin.
We'll have discussions on that next. So next, please, Archana, move on to the next slide. Archana, please move. Yeah. So now we have the next question for Dr. Prachi Singh. Now, what happened that this patient, she was told not to get pregnant, but she got pregnant, and now when she has come without a proper control, her hemoglobin A1C is 13%. So do you monitor your patients with hemoglobin A1C during pregnancy, Prachi? And what is the risk in this case?
Thank you, madam, for this question. Actually, periconceptual hyperglycemia is strongly associated with the risk of congenital malformation, and there is exponential increase in malformation as the glycosylated hemoglobin increases. If it is less than 5.5%, according to International Association of Diabetes in Pregnancy Study Group, if the HbA1c is less than 5.5%, the risk of anomaly will be 2%, which is that of the general population. But as it increases, if it becomes 5.6 to 9.5%, then the congenital malformation rate increases to 4.5%. And if it is more than 9.5%, it is around 22%. So in this case, the congenital malformation rate would be around more than 22%. So then we have to counsel accordingly whether she wants to continue the pregnancy. If she's pregnant at present and the pregnancy is well and good, then we'll have to counsel her that this is the incidence of malformation and give her the choice what she wants to do.
Very well said. Now, what I wanted to know whether you are monitoring your patients with hemoglobin A1C. What test are you doing once you have diagnosed GDM or
Madam,
diabetes?
I'm not doing glycosylated hemo because it takes a long time for it to change, and we have to monitor the patient on a day-to-day basis if she's type 1 or if the blood sugar is very high. So it is difficult to manage with glycosylated hemoglobin. We are doing with fasting and PP. I'm doing it with fasting and PP.
Yes, but nowadays some guidelines, they are recommending that in second and third trimester you can do monthly hemoglobin A1C. But if we get a case of GDM, we know that this hemoglobin A1C, it does not tell us about the postprandial hyperglycemia. And that postprandial hyperglycemia is mainly associated with macrosomia. So I think for us, fasting and PP is more practical than doing hemoglobin A1C. And in first trimester, definitely, hemoglobin A1C will tell us what was her preconceptional control and what was her control at the time of organogenesis. Okay, so now we move on to the next slide. This is case number 2, and this next, please. And this goes to Dr. Ranjana Jha. Is she there?
Yes.
Okay, so Ranjana, this is another patient. She is a primigravida. She has presented in the first trimester. Which protocol do you prefer for screening for diabetes? How to do DIPSI test and what are the advantages of DIPSI?
In my practice, I am preferring DIPSI test in every patient, but some patients do not ready for doing this because they have already so much nausea and vomiting. They are not ready to take glucose. But I prefer in all. But I prefer in each and every patient, I advise for DIPSI test.
So do you do it universally or selective screening?
No,
What is
I
your
do
practice?
each and every patient whenever she comes in first time to my clinic. In each and every patient, I am doing.
Okay, next please. So now what, when you do this test, what, do you do it once, twice, thrice? What is your protocol for testing?
First time when she comes to us, then if this test is negative, then again at 24 to 38 weeks, at 24 to 28 weeks, and again I am doing at 34 to 36 weeks. 3 times I am doing.
And this is what even the Ministry of Health and Family Welfare is also recommending, that you should do it. And especially if first test is negative, then also we should repeat it again at 24 weeks.
28 weeks. Yeah.
And then again at 32 to 36 weeks. And we have an expert with us, Dr. Archana Jha. I would also like to know her opinion about doing the screening test. What is your opinion and what are you doing, Dr. Archana?
Yeah. As we know, we are the capital of diabetes. So we have made many of cases with a family history of diabetes, and many cases comes with the gestational diabetes also. So it is very basic to do the universal screening in all of cases. And we should do it first visit, as you have already told, the three tests should be done. And it should be done with the 75 gram of glucose with 200 ml water. In spite of her dietitial status, whether she has empty stomach or she has taken food, and we will do plasma glucose level after 2 hours. And when the level is more than 120, then we can, when it is more than 140, then we can go for oral glucose tolerance test in that case. And HbA1c will also be done, and it should be less than 6.
Okay, next, Archana, please. Dr. Ranjana, can you quickly tell us about the advantages of doing DIPSI? Dr. Ranjana?
It is very important. It is very practical test, as in this case, the patient has not to be fasting. There is no, irrespective of the meal, and moreover, we can pick up more cases. If we screen only the high risk cases, on half of the cases will not be picked up. But once we screen, all the universal screening is applied with the DIPSI, we pick up more cases at the booking. And even when we are minded towards it, and we have to have a high index of suspicion, not only screening only the targeted population will not be able to pick up all those cases who are potential diabetic.
So the message is universal screening by DIPSI, and to all women who come, and it is a non-fasting test.
मैं वापस आ गई मैम इधर
ठीक है
कोई बात नहीं.
There is another question for you, Dr. Ranjana.
हाँ, next question.
बर्फ बहुत गिर रहा है, इसलिए मेरा नेट चला गया था. I am back again.
Okay, Ranjana, this is the next question for you. Now, this patient, she underwent DIPSI test and her value is 149 milligram per DL. What next?
In first trimester, ma'am.
Yeah, this was
first visit. Yeah,
first visit.
Yes, so is definitely more because the cutoff is 140 milligram.
Okay.
Usually, gestational diabetes occurs in second and third trimester, but definition is whenever in first time diagnosed, it is gestational diabetes. So I will call it gestational diabetes. And also in first trimester, so I will also do HbA1c in this patient also.
Okay.
To know the previous 3 months blood glucose level.
Okay. So now what are the targets in pregnancy? This is a chart which is showing the targets given by all the authorities like FIGO, ACOG, ADA, that fasting should be less than 95. 1 hour post meal should be less than 140. 2 hour post meal should be less than 120. And hemoglobin A1C should be between 6 to 6.5 by ADA and less than 6% by NICE.
Nice.
So, but the what we are doing in a practice, we have to understand that the first screening test is DIPSI, and we had to look at only one value, that is 140. If it is between 140 to 200, it is GDM. If it is more than
200,
200,
diabetes.
it is diabetes in pregnancy. And if it is less than 140, and then in that case, if it is in the higher range, we have to counsel the patient regarding lifestyle changes, but we do not label her as a case of GDM.
Okay.
So now, next please. So so what are the therapeutic options? I think Archana, you can take up from here.
Yeah, thank you, Dr. Abha ma'am, for giving me to conduct the session forward. So continuing with the same case number 2, where her 2-hour oral GCT test had shown blood sugar level of 149 milligram per DL. So we all know that here the cornerstone of the management will be medical nutrition therapy to start first. So I would just like to know from Dr. Sudha Jha, what are the principles of MNT and for how long you're going to give MNT?
Good evening, everybody, and pranam to seniors. And thanks to the organizer to giving me the chance. Now, the patient is in GDM, and our aim is good glycemic control and better perinatal outcome. And for this, 70 to 80% of cases, MNT, we will solve by MNT, medical nutritional therapy. Of course, added with lifestyle modification and exercise. And
so,
this.
For how long you are going to first try MNT?
Yes, MNT should be tried for about 2 weeks. And if by this blood sugar is not controlled, then we will add insulin. And
but we just want to focus for now on MNT. Would you like to describe the?
I just describing. In MNT, we do nutritional counseling, and counseling is a teamwork. It involves the dietitian, endocrinologist, and the obstetrician. It is the whole teamwork, and all together we do work. And here we construct the calorie. A calorie should be about 30 kilocalorie per kg body weight in whole day in a spread out manner. It should be plus 5, minus 5. If the patient is lean, then you can add plus 5, or we can minus 5 if the patient is obese. And it should be spread out in 3 major meals and 3 minor meals. And the composition of the food should be 40 to 45% from carbohydrate, and carbohydrate should be of complex type, of low glycemic index, and 30 to 35% from fat, and it should be preferably from monounsaturated and polyunsaturated fat, and protein should be 60 grams per day. And if the patient has renal involvement, then the protein should be cut off and in lower limit. And it is good to split the breakfast into 2 because of more insulin resistance. And in lunch, there is major meal and added to a small snacks. In night, the dinner should be early, and it should be added with light snacks. And this light snack should consist of complex carbohydrate of the low glycemic index and protein. And this snack will prevent late night hypoglycemia, as well as it will prevent early morning ketosis due to less of glucose. So the cornerstone is a spread out meal, 3 major meals and 3 snacks. to avoid glycemic variability.
So thank you,
And
Sudha
also,
ma'am, for
and
very
also
well summarizing
self-glucose
the
monitoring, self
very
glucose
well
monitoring, and
summarized,
also
Dr. Sudha
exercise.
ma'am. Yeah, very
Yeah.
well summarized. Medical nutrition therapy by Sudha ma'am. The basic is to, but the calorie requirement will depend upon the pre-pregnancy BMI, which you also highlighted. Average is 30 kilocalorie, but you can add +5, -5 according to the pre-pregnancy BMI. And very well you explained that meal needs to be staggered in 3 mesa meals and 3 snacks to avoid glycemic variability. And in simple language, when we explain to the patient, we say that 1/2 of the thali should be filled with vegetable, which could include cooked food as well as salad. And 1/4 will be your cereals and 1/4 will be protein. And of course, you explain all those things very well. So could you also elaborate a little bit about exercise? Because we always advise exercise along with the diet. So briefly, you could just elaborate on what type of exercise and for how many hours we need to exercise.
Moderate intensity exercise should be done, and it should be done after not in empty stomach, and very harsh exercise should be avoided, and we should care for the
It should be brisk walking or arm exercises while sitting in the chair. 10 minutes after meal, because after meal doing exercise take care of the postprandial hyperglycemia, which usually drives microsomia. And doing the physical activity actually improves the insulin sensitivity at the skeletal muscle level. So all those help in reducing the insulin requirement as well.
So dictate means 15 minutes of exercise after 15 minutes of meal.
Yes, so we move ahead with the same case. After 2 weeks of her medical nutrition therapy and exercise, her results on the fasting and PP blood sugar was like this: fasting 110 and 156 2 hours postprandial breakfast. So now, Doctor, I would like to ask my good friend, Dr. Imrana. You have decided to start on pharmacotherapy and you have convinced the patient for insulin therapy. So what are the different type of insulin which are used in pregnancy, and how frequently do you monitor these women on insulin therapy? I mean, you need to elaborate on self-monitoring blood glucose as well.
Yeah, regular exercise and MNT has been done, and she's not, they're not able to. The most important is it depends upon the her lifestyle.
So I just want you to highlight what are the different types of insulin and which practically what kind of insulin you are using in your practice.
Using both. Personally, I'm using both. Many a times I'm doing it on my own capacity, in my own tackling all these patients on my own merit. Otherwise, I'm liaising for difficult cases who are very obese or may are pregnancies sometimes.
You're involving an endocrinologist as well while you are using insulin.
Yeah, I use Actrapid because it's easier to dose the patients, and all the most important thing is how you counsel the patients and take into confidence, and how to you encourage self because you got a lot of pens are also available nowadays. Different insulin analogs are also there. Is Lispro, Aspart for short acting, and then we have dedicated. But I'm using typically a Mixtard with 30 and 70, Isofen 70 acting, and that is third of the dose has to be breakfast in 1/3 in the night time, and you calculate the dose as per the gestational age. That is 0.7, 0.8, and 0.6, 0.7 units per kg of body weight. Accordingly, it's best for the practical, for all practical purposes. We need to go for 4 units of Actrapid, or if we decide with an insulin, if we are having it between 120 to 160, and then 150 to 160, it is 160 to 200, it is 6 units, and 200 above, it is 8 units. So the our aim and target is to put a FBS between below 95 and 2 hours postprandials, because all we need to mind is the postprandial excursions and surges. which has to be left below 120. And hypoglycemic alerts have to be explained to the patient regarding tremor, sweating, hunger, easy fatiguity, all these things, and really explain. So our target is in subcutaneous 30 minutes before meal. I advise them pen because it's very easy, self-administered, and initially for the doses, she can at the night and postprandial she can check her insulin. Otherwise, I give a 3-day check, 3 to 8 days per day. I give a check of like blood glucose by the for just initially titrating the, and evaluate the diet, add insulin as well, because metformin is a good insulin sensitizer.
We'll discuss about metformin later. Just right now, we are focusing on what are the different types of insulin, why, what is the purpose of insulin, using long-acting insulin, which we want to meet to maintain the basal level of the glucose. Short-acting insulin are just given to take care of the immediate postprandial blood glucose. And you rightly said the total dose of insulin varies from 0.6 to 1 unit per kg per day. And after we calculate the total dose, we need to divide it into morning, 2/3 of it is given morning, and a night 1/3 of the total dose is given. And in morning, we prefer to give 2/3 as long acting isofen and 1/3 short acting. And in night dose, we are dividing half into long acting and half into short acting. That is a general principle. But of course, we have to individualize the insulin requirement according to the patient response and further monitoring. So with this, we move ahead to what kind of self-monitoring of blood glucose. So we are advising to the patient how many times you are doing it, and just a little bit explanation on that.
And pre and postprandial, but it becomes really cumbersome for the patient, and patients sometimes run away giving all the pricks. It becomes really difficult for them. So staggered is fasting and PP approach is there at least once a
But
day.
initially, you have to take 7 samples, right, for just to stabilize the glucose level. And once it is stabilized, we move on to only 2 or 3 samples in a day.
So we'll do that.
Yes.
And Archana, I'd just like to mention a point here that whenever you are doing the staggering approach, try to make it different every day. Like sometimes you take it post-meal, sometimes you take it pre-meal, sometimes pre-breakfast, sometimes post-breakfast. So you get an exact idea that what is a blood sugar control. And what Anita told us in her morning speech, that not getting the this blood sugar monitoring for 10 days, I think that is a big crime. Because these patients are glucose levels is always they are changing, fluctuating and changing. So you always need to monitor them very closely.
And once a week, get it confirmed from lab as well.
Yes, after 1 week, you should get the venous samples sent. Yeah.
So that is the take-home message. And sometimes we need to do 3 a.m. Glucose also to just to know whether it is Somogyi phenomena or dawn phenomena. But and nowadays, the continuous glucose monitoring facility is also available, which will give us idea when, at what time of the day the target was not was less, or at what time of the day the target was more.
Rating insulin, isn't, with the glucose sensor.
Yes. So with this, we move on to the next part of the pharmacotherapy, that is oral hypoglycemic therapy. So I would like to know from Dr. Rupam Singh, just tell us briefly about what in your clinical practice, what oral hypoglycemic you are using and what are the advantages of using metformin?
In OADs, we have metformin and glyburide. And glyburide is metformin is, of course, the first choice, better choice than glyburide, because it reduces gestational weight gain, and fetal birth weight is also reduced with metformin. Along with that, there is reduced risk of fetal neonatal hypoglycemia and macrosomia. Along with there is less incidence of PIH with metformin. So it is a better choice. Metformin is better choice, and we can take OADs. We can initiate OADs as a first choice in cases where the fasting blood sugar is normal, but the postprandial blood sugar is it is not it's moderately elevated. In this case, we can initiate metformin or glyburide as a first choice. And of
main
course,
advantage is that it does not have a hypoglycemic episode. It does not stimulate fetal pancreas. And one caution is there, it should not be used in women with preeclampsia or high risk cases for FGR, because it can cause fetal growth restriction or acidosis in the setting of placental insufficiency.
Okay.
There are many studies about it. This is one of the study which was published in BMJ Open, and this says that maternal exposure to metformin and combination of metformin or insulin was not associated with increased risk of obesity, hyperglycemia, and other problem compared with insulin and metformin, but significantly increased risk of being small for gestational age. This suggests it to be used with caution in fetal, where the fetus is at risk of growth restriction. And this is another study which says that metformin treatment in PCOS, this is a meta-analysis of the effect of metformin on pregnancy outcome in women with PCOS. This says that it can be used from conception till birth, and it has got advantages because it increases the possibility of term delivery and reduces the complication like GDM and PIH in women with PCOS. So, regarding glyburide, can you like to share some experience?
I don't have any personal experience about glyburide, but metformin I have used frequently.
Yeah, because we also are mostly using metformin.
And one more thing is that compliance with metformin is good, and it is a cheaper alternative for insulin too.
Yeah, but glyburide, the studies have shown that it is sometimes can be used in patient of GDM as first line treatment where failed therapy with diet alone. And it is, of course, a sulfonylurea drug. The starting dose is 2.5 milligram once daily or twice daily, and total maximum dose is 20 milligram per day. And increments to be done weekly until desired effect. But most of us have more experience of using metformin.
But the incidence of fetal neonatal hypoglycemia is more with glyburide.
Yeah, that is the main side effect is hypoglycemia. Yes.
Yeah.
So this is the recommendation from different authorities about use of insulin and metformin. Ministry of Health Family Welfare has recommended use of both insulin and metformin. DIPSI also recommends the same. NICE guideline also recommends both of them. But ACOG 2019 offers metformin only to those having, I mean, the long-term safety is not established. They are not recommending very well about metformin. Glyburide is not recommended. And American Diabetes Association has also not recommending metformin and glyburide use. So with this, we move on to case number 3, and I hand over to Dr. Abhasina ma'am.
Thank you, Archana. So now we move on quickly to the case number 3. And I think Apurva, are you there? Dr. Apurva Datta? If Apurva is not there, then I think Dr. Prachi can take this case. Prachi, are you there?
Yes, madam.
Yes, so you can take this case. Apurva, I can't find Apurva. So she's a G2P1L1. She presents at 34 weeks of gestation. She had a history of GDM in a previous pregnancy. She had a history of a full-term vaginal delivery of 3.7 kg baby boy. And she had been diagnosed as GDM in this pregnancy and is controlled on both medical nutrition therapy and insulin. Now, I would like to know that how do you diagnose macrosomia in practice, and what are the measures taken to prevent macrosomia?
Madam, macrosomia we will diagnose on most of the time we do it on ultrasound now when the abdominal circumference is more than 90th centile or the estimated fetal weight is more than 90th centile. Then that is how we diagnosed. And other than that, bisacromial diameter more than 15.4 centimeter, or definitive if AC is more than 35.5. And regarding prevention, madam, if postprandial blood sugar is well controlled, then macrosomia, the incidence is reduced. But if the postprandial is very high and it is fluctuating, then
so a good glycemic control is the best way to prevent macrosomia, and especially the postprandial blood sugar. Very well said. And there are some new markers, like they have come up with transverse fetal thigh diameter, 3-dimensional USG, fractional limb volume, and subcutaneous fat over arm and abdomen. Can you go back to the question, Archana? One slide back.
Yes.
So can you, yes. So would you like to induce these cases before term once you have diagnosed macrosomia?
Yeah, because of the risk of the shoulder dystocia.
If the estimated weight is more than 4, then I don't think induction should be done. But if it is less than 4, then
I think I can see Apurva. Apurva, you have joined?
Hello.
Okay.
Yes, ma'am. I was there. Actually, I had some emergency. So.
Okay, no problem. So what is your opinion regarding fetal macrosomia? Will you go for induction in these cases where you suspect fetal macrosomia?
Ma'am, for prevention of the fetal macrosomia, for prevention of the shoulder dystocia, there are 2 management which is described to have reduced the shoulder dystocia. One is the induction at 39 weeks of gestation age when the cervix is favorable. Definitely.
So, but not premature induction,
not premature induction, definitely. But it should be at 39 weeks, not before that, unless and until there is some another maternal or fetal indication. If there is AOGR, there is some another obstetrical causes, then we have to go for. If there is not any emergency, we will induce at 39 weeks of gestation. That is the main thing. Secondly, if it is not favorable or like glycemic control or some another obstetrical indications are there, then we have to go for the cesarean. That is the only things to terminate. Yeah, ma'am.
What fetal weight do you consider for going for an elective C-section?
Ma'am, it is more than 4.5 kilo.
I think 4.5 is for Western countries. Our pelvis,
4
I think
4 is enough.
4 is
enough for us.
4 kg.
4 kg. I think our cutoff should be a bit low because our women's pelvis is a bit narrow. Their capacity is less. So, and I think everybody should practice shoulder dystocia drills because it is an unpredictable complication and it can occur in any patient. So I think this is one way to prevent shoulder dystocia. And in all cases where you have a failure to progress during labor or there is a second stage arrest, always suspect macrosomia. Maybe you're wrong with your ultrasound findings. So go for an early sections to prevent morbidity. And next, please, Archana. So when to deliver? I think this is a big question, Dr. Apurva. If GDM on diet?
Yes, ma'am. Suppose that patient is a known case of diabetes and it is only on dietary control. So we can, take up to the 40 weeks. There is no problem. But suppose that if it is on insulin, everything is okay, but we have to induce the patient at 38 weeks to terminate the pregnancy at 38 weeks, whether everything is okay. But if the patient is in insulin, we have to terminate at 38 weeks. That is the thing.
And if it is a complicated case, that will depend upon the associated complications. You may even, if there is a gross placental insufficiency, you may even have to terminate at 34 weeks after giving steroids. So do you prefer to give steroids to patients with GDM?
Yes, definitely.
Ma'am, we should give, but it should be, patient should be admitted in the hospital. In diabetes patient, when we are giving the steroid coverage, she should be admitted in the hospital, then give the steroid coverage, then because
especially if the patient is on insulin. Especially if the patient is on insulin, because sometimes the requirement of insulin may increase. Yes, Dr. Archana, yes, please give your views. We have an expert.
We should give steroids in the pregnancy less than 34 weeks because it have more benefit. And we have to adjust insulin dose accordingly if needed.
Good.
Because it can lead to hyperglycemia.
So that is very important that we may have to adjust the dose of insulin. Okay, now Archana, I think you can take it further.
Yes. So now this is for Dr. Anjum Mariam. At 38, now this patient, the same case number 3, has her BISOP score 4 and estimated birth weight is 3.4 kg. So how will you proceed? Whether you will plan cesarean or you will proceed with vaginal delivery, and you need to discuss intrapartum management in brief.
Okay, ma'am, as her previous birth weight, as the birth weight is 3.4 kg. So in this pregnancy,
Previous
we can go for vaginal delivery.
3.7
And,
3.7 kg. Yeah.
That's okay. And now it is 3.4.
So
3.4. Yeah.
Yeah. So we can go for vaginal delivery. Cesarean section is done only for obstetric indication. And
Yes.
as our Bishop score is 4, so we will go for induction. We have to do the priming of cervix. We can use the PGE2 for induction of labor. And the induction should be done in the morning. And prior to the day of induction of labor, the usual bedtime dose of insulin is given, and the morning dose should be withheld. And on the day of induction, we have to maintain the blood sugar level between 4 to 7 millimole.
I think her connection is lost.
Yeah.
So
anyone can take over? Huh.
NS infusion has to be given, and the blood sugar has to be maintained between 4 to 7 millimole per liter. And
So how frequently you would like to monitor her blood glucose level? How frequently?
Hourly, 1 to 2 hourly, hourly
Yes,
blood
because
sugar
if she is
monitoring
on
should be
insulin
done.
hourly, yes.
Yeah, hourly blood sugar monitoring should be done. And along with that, we have to do CTG, electronic fetal monitoring, and the monitoring of the vitals of the patient, which includes the intake and output chart and the
Again, her connection is gone, I think.
Dr. Anjum, switch off your video.
I think most of the things she has already mentioned.
Yeah, she has already mentioned about most of the, she has highlighted almost all the salient points. And just to
1 liter of fiber.
Yes.
Yes, Dr. Anju.
Yes, ma'am. We give NS infusion. We give NS infusion, and
Yes.
if the IV fluid, if the blood sugar level is less than 17, then we have to give 5% dextrose with insulin. Okay, and if the blood sugar is between 90 to 120, then no insulin is required. And if it is 120 to 140, then in 500 ml of NS, we have to charge 4 units of insulin. And that has to be
Regular
infused
insulin,
at the rate of
Yeah.
100 ml per hour.
Yes. And for every 40 milligram glucose increase, you need to add 2 units.
2 units.
So that is a simple formula which can be remembered by everyone. So now I think Dr. Ma'am, you will.
Yeah, now we are moving into the last part. Now this is for Dr. Geeta. How will you manage blood sugar levels after delivery, and how will you counsel the women at the time of discharge? These are just the closing slides.
For the management of blood sugar following delivery, if the patient is a pure GDM patient, then immediately after delivery, the blood sugar comes to the normal level. And
Archana, please share the slide.
The blood sugar comes to the normal level, and in those who were on insulin, the requirement for the dose decreases immediately following delivery. So the patient should be counseled about frequent meals or frequent snacks, because there is high risk of hypoglycemia. And if the blood sugar level following delivery comes to normal in the GDM patient, then no further monitoring is required till 6 weeks postpartum. And in the 6 weeks postpartum, in the 6 weeks postpartum, we monitor the fasting blood glucose level and the glycosylated hemoglobin level, and the fasting blood sugar level. If it is less than 108 milligram per deciliter, then we counsel the patient that the risk of developing type 2 diabetes later in the life is comparatively less, but still she requires annual monitoring of the blood sugar level. Those in whom the blood sugar level is between 108 to 126, there is moderate to high risk of developing type 2 diabetes later on in the life. And the blood glucose monitoring should be done more frequently, and lifestyle management, which includes weight control, dietetic control, and exercise, that should be advised to them. And if the 6 weeks postpartum blood sugar level is more than 126 milligram per deciliter, then we can say that they have type 2 diabetes mellitus, and we should be further confirmed by other tests, and they should be managed accordingly. And
what about contraception? What about contraception, Dr.
Yes, ma'am.
Geeta?
And they should be advised about the contraception, among which barrier contraception or progesterone only pill or very low dose OC pills can be advised.
What about
IUCD we can use?
Yes.
IUCD we can use.
Avoid IUCD.
No, nowadays it's not needed to avoid. Uncomplicated cases you don't need to avoid.
Uncomplicated cases we can give IUCD.
It is category 1. Yeah.
Madam.
Yes. Yes, Prachi, you want to say something?
Yes, madam.
Yes.
Hearing a panel discussion, and they were saying that progesterone only pill should not be given in GTM patients because progesterone causes insulin resistance. So that should not.
The best choice is LARC, that is long-acting reversible contraceptives like IUCD.
Not plant or ICD, yeah, not plant.
Yes.
And we have left the fetus.
POP is 2. POP is not 3 and 4, but POP is 2 for diabetes without complications. But it's not the ideal choice.
Yes.
Next. Next, Archana. Yes.
We come to the last slide. Thank you.
Okay. Thank you. Thank you, organizers. Thank you, Nivedita, Bokaro Society.
Thank you, madam. It was really very good.
Alka, the whole team. For organizing. And thank you, Anita B. Rangila madam, for giving us this opportunity.
To Anita ma'am, Rangila ma'am, and
Pallavi di, of course.
Thank you.
Thank you. बहुत अच्छा प्रोग्राम था मैं पूरा सुनी हूँ.
Hey, please stop sharing, ma'am. Archana, please stop share. Archana, please stop sharing.
Ma'am.
Thank you.
मेरी बारी.
Congratulations, Nivedita. Congratulations.
Very interesting.
Very nice.
Thank you. Very nice. I enjoyed thoroughly.
Thank you. अभी
Not
वोट
only the
सबको देना
company,
है.
but the
Thank you, Rangila madam, Ushanath madam,
लेकिन
Pratibha madam.
लेकिन रंगीला मैडम लास्ट तक बैठी रही, सबसे बड़ी बात यही है. रंगीला
ये
मैडम
बहुत बड़ी बात है. ये बहुत बड़ी बात है. पल्लवी मैडम,
सीखो ये सब बात.
मैडम, we need your blessings. मैडम, आपका आशीर्वाद चाहिए.
बोकारो सोसाइटी के बिहाफ पर मैं डॉक्टर निवेदिता, प्रेसिडेंट बोकारो सोसाइटी, आप सबका हार्दिक दिल से धन्यवाद देती हूँ. मतलब ये वेबिनार, ये वोट ऑफ थैंक्स was supposed to be given by Dr. Anupriya, but because her father is not doing well, so she has gone to the hospital. Hence, I'm delivering the vote of thanks on her behalf. सबसे पहले तो a very, very big thank you to Rangila Sinha ma'am and the founder, president, patron of AOGSBJ. Dr. Anita Singh ma'am, President AOGSBJ, and Pallavi Roy ma'am, Secretary General AOGSBJ. इन्होंने बोला कि बोकारो सोसाइटी को एक प्रोग्राम करना है, and I said that ma'am, let's do, if we can do it online, and they agreed immediately. So a very big thank you to them to give us this opportunity to have this webinar on ensuring safe motherhood. Thank you for the excellent talk, Anita Singh ma'am, and for the chairpersons to have logged in, Dr. Pratibha Rai ma'am and Dr. Usha Nath ma'am, both of whom are real darlings, and they always are there for me. I thank all the moderators, all the experts, and the panelists for the two wonderful panels on which I think obstetricians need to know about these two panels, and this is stillbirth and gestational diabetes mellitus. I thank all the presidents and secretaries of all the societies of Bihar and Jharkhand for putting in such an effort and encouraging their society members to join this program and for being there with us. My whole team of Bokaro, and which has been represented by three main people here, Divya, Alka, and Varuna. But my team, I love them because they're always there with me. Today, it's represented by these three. Tomorrow, it's by somebody else. And last but not the least, I would like to formally thank Shield Pharma for always being there to be our technical support. Thank you, everybody, on behalf of Bokaro Society.
Thank you.
Thank you, Niveta.
Thank you, madam. Thank you, everyone.
Thank you all.
Thanks, Savita. बहुत अच्छा रहा.
Thank you.
Bye bye.
Thank you. Long live